Talk about so we're going to talk about heart failure and circulatory shock. So let's start first with heart failure. So what is heart failure? Heart failure is the failure of the heart to maintain adequate cardiac output to meet metabolic demand. So whenever the heart is not maintaining enough cardiac output to meet metabolic demand, the heart is failing. Now, that could be because the heart is weak and is not able to maintain the normal cardiac output. But it could also be that there is an unreasonable metabolic demand, in which case the cardiac output is actually higher than normal, but it's still not sufficient to meet the metabolic demand. So, heart could fail absolutely or relatively. You got that? Mm-hmm. Excellent. I think that's what I'm saying. Good. So, it is on that basis that we classify heart failure into 3 types. Okay? We have low output failure, usually written as heart failure with reduced ejection fraction, right? They call it HFrEF and HFpEF. You know, these crappy acronyms. I hate them. So, you have low output failure, you have normal output failure, and you have high output failure. So in low output failure, that is when the heart is not able to maintain the normal cardiac output. Low output failure is when the metabolic demand is not unreasonable. It's a normal metabolic demand, but the heart can't measure up. Okay, so it fails. So even though we define heart failure as failure of the heart to maintain adequate cardiac output for metabolic demand, it's a relative thing. Okay? You understand that, right? When the metabolic demand is normal and the heart is not able to meet it, that is a low output failure. And generally there is ejection fraction less than 40%. A normal heart will pump out 40 to 60% of whatever it gets. Right? When the heart pumps less than 40% of what it gets, there are 40% of the end diastolic volume, EDV. Okay? You can get that from volume overload when you have valves and fluid dysfunction. You can get it from ischemic damage when you have atherosclerotic coronary artery disease. You can get it from dilated cardiomyopathy. So you know all that now, right? Okay. Now, normal output failure, the so-called HFpEF, basically is heart failure with preserved ejection fraction. Okay? That is usually due to what is called diastolic dysfunction. And you get it when you have pressure overload, hypertrophic cardiomyopathy, or restrictive cardiomyopathy. Because what is happening is that the heart has sufficient pump power, but it's not able to fill because it is stiff. Okay? So, cardiac output is reduced not because the heart is weak. The heart is really strong. But it's pumping out what it gets, but what it gets is so little that even if it pumps out 60% of it, it is still not sufficient to meet metabolic demand. So, I mean, think about it. The ejection fraction is supposed to be 50 to 60% of end diastolic volume, right? Right? End diastolic volume, 60%. So if the heart is so stiff, okay, say normal end diastolic volume is 100 cc. the normal heart will receive 100 cc and keep it straight, accommodate it, contract on it, and get rid of 60 cc or 50 cc, normal heart. A restricted heart, or a heart with pressure overload, you know, pressure overload causes what kind of hypertrophy?
Concentric.
Thank you. Because it's concentric hypertrophy, right? That makes the heart stiff, right? Make it stiff, becomes unyielding. So it can't fill up to 100 cc. So because it is stiff, it fills up to 60 cc. Well, it could have all the strength it needs. It could get 50 to 60% out. That is never going to be a normal cardiac output. Right? You understand that, right?
Yeah.
Okay. So that is what we say. Even though the ejection fraction could be normal, the amount of blood, because the denominator is so reduced and compromised, the amount of blood that is represented by that normal ejection fraction is insufficient. All right, so you find normal output failure in diastolic dysfunction. Usually pressure overload. It could be valve problems like aortic stenosis, or even aortic aortic coarctation. It could be due to hypertension. Okay. It could be due to hypertrophic cardiomyopathy. Remember that, and restrictive cardiomyopathy, right, where the ability of the ventricles, left ventricle especially, to dilate and receive blood is compromised, so that the end diastolic volume is reduced. So even though you have normal ejection fraction, the quantity, the amount of blood that leaves in a minute is reduced because of that. Right? Good. Now you have high output failure. This is the one where a normal heart is trying very hard to meet a very high metabolic demand. Okay, you find out in severe anemia, hypothyroidism. It's called wet beriberi when you have thiamine deficiency leading to heart failure. There is dry beriberi. You do that in nutrition, right? Oh, yeah, okay. There is dry beriberi and wet beriberi. Wet beriberi is thiamine deficiency leading to heart failure, and patients become edematous, so it's called wet, right? And then you have AV shunts and fistulas. As in Paget disease, when the shunts and fistulas are in the bones, and then you have hereditary hemorrhagic telangiectasia. You talk about that, right, in hematology and oncology, right? You didn't talk about hemorrhagic telangiectasia?
We know what telangiectasia is.
Well, you know what telangiectasia is, right?
Yes. Yeah.
Well, telangiectasia is the one that this hereditary hemorrhagic telangiectasia is the telangiectasia that bleeds and the kid is born with it. Got it. Okay. So basically what it does is this telangiectasia, they shunt blood from the arterial side from the venous side to the arterial side without going through the rest of the circulation. And they behave exactly anatomically like a fistula. Okay? You understand the implication when you bypass the capillary beds. It's like you're making, in fact, when you bypass the capillary bed, basically you are making the left ventricle pump the same amount of blood that is shunted over and over again. So it creates a kind of volume stress on the left ventricle. Okay? But what I want you to know is that heart failure can be low output, normal output, high output. In anemia, for instance, well, there is hypoxia, not because the heart is weak, but there isn't enough blood to carry the oxygen, right? So because the blood is so dilute, the blood does not have enough hemoglobin carrying oxygen, the body tissues require a lot more rapid flow, right? To get the amount of oxygen they need. So think about it. You're all eating lunch now. If I give you, you know that little wooden spoon they used to serve table salt, right? If I have you eat with that spoon, and I say you have to finish your lunch in an hour, you're gonna have to eat a lot more faster than you will with a regular spoon. So it's like blood is full of hemoglobin. Hemoglobin is 3 grams instead of 15 grams. So blood is flowing in adequate volume, but the oxygen is not enough. in order for the body to get the amount of oxygen it needs delivered by a normal 15 gram hemoglobin, that blood that has only 3 grams has to come around like a lot more often. So that is an unreasonable metabolic demand on the heart. So the heart will fail ultimately. And it will fail with an ejection fraction that is above normal. In other words, it's trying really hard, but it's not able to meet that demand because it's an unreasonable demand placed by this severe anemia. The same thing happens with hypothyroidism and AV shunts and stuff like that. So that is how we classify heart failure. So low output heart failure with reduced ejection fraction is also known as systolic heart failure because it's a pump failure. And heart failure with preserved ejection fraction is known as a diastolic failure because it's a failure of the heart to fill adequately in diastole. It's the failure of the heart to relax and receive blood so it can pump it. So it's a diastolic heart failure, okay? And then you have the normal heart that is killing itself because of high output failure, all right? So again, this is what it looks like. Ventricles fill normally with blood, ventricles pump, blood leaves. That is normal. In systolic, well, the enlarged ventricles fill with blood, but it's not able to pump. Either because it has been taken up by multiple MIs, or it's been infiltrated by sarcoid nodules, or iron bodies, like in hemochromatosis. For some reason, it's not able to pump. Right? So ventricles pump have less than 40 to 50% of the blood they receive. And then diastolic dysfunction, the ventricles are stiff. So the stiff ventricles fill less with blood than usual. And of course it will pump out what it has, but invariably because what it has is so little, it pumps out just as little. Right? Okay. So we talk about heart failure. It's not enough to say somebody has heart failure and keep quiet. No. You have to say this patient is in florid heart failure and I think it's a diastolic dysfunction. And I say, why? He said, because he has LPH and the CKD, he has history of hypertension. I think it's a diastolic dysfunction. Hey, that means you really know what you're talking about. Right? And that's how I want to talk about these things. Is it hard?
No, I'm just closing the door.
Oh, okay. All right, so now let's think this through for a minute. What really happens? What really happens when the heart fails? So now, let's go through the pathophysiology of a failing heart. So when the heart fails, usually it is the left that fails first, because it's the one that is responsible for systemic circulation, right? So let's start with the left ventricle. Don't write, just listen to this story. It's a very sad story. So the heart on the left side just suffered a massive heart attack. It can't pump blood anymore as effectively as it used to. What will happen immediately is that the ejection fraction will go from 50% now to 20%. Right? So that means when that ventricle that used to receive 100 cc at the end of the diastole, when it had its muscle, will pump out 50 cc and can receive 50 cc from the left atrium to make up the 100 and pump the 50 cc out again. Now it has suffered a loss of its muscle. So instead of pumping out 50%, it pumps out 20%. That means instead of 50 cc, it only pumped out 20 cc because we're working with the end diastolic volume of 100 cc, right? So now it has 80 cc left after every beat, right? That means the right atrium cannot empty the 50 he used to empty. It can only empty the 20 that left, the left ventricle. So if the left atrium cannot empty the 50 it used to empty, that means it can only empty 20, it now holds on to 30. And the lungs don't care. For as long as they receive blood from the right ventricle, they're going to dump it over it. So what happens? The pulmonary veins start getting engorged because the left atrium is not empty and they are getting bombarded by this pulmonary venous return. So they start getting engorged. So you get venous distension. When the venous circulation start getting distended and congested, all those tissue fluid forces formation start kicking in. Fluid starts seeping out. We know what happens. Whenever blood sits still, the water in it seeps out into the surrounding tissue. We call that edema. Okay, that's exactly what happens in the lungs. And because it happens in the lungs, we call it pulmonary edema. So the alveolar space that is supposed to be filled with air now start getting filled with fluid. That's the next thing that happens. And because the pulmonary veins can't empty into the left atrium, the right ventricle cannot push blood into the lungs because it's backing up. So the right ventricle begins like, what is going on? Because the vena cava are not waiting. They are dumping the blood just like they used to. But now the right ventricle can't empty because there is no space in the lung. There is no space in the lung because there's no space in the left atrium. There is no space in the left atrium because there is no space in the left ventricle. Now, the right ventricle now start getting, come on, let's go. It start getting big, trying to force its way through. What happens? Very soon, it start getting enlarged, but because the lungs are not yielding, because it's not their fault, the left ventricle is the one having the issue, they start like, okay, I can't get this volume out. You guys can dump it all you want. But once it's full, it's full. Our country is full. Right? So the right ventricle is like, hey, you guys can't keep coming here. Our country is full. Then the veins start getting congested, right? And then once the veins start getting congested, the same thing that happened in the lungs start happening in the systemic veins. And you begin to get peripheral edemas, just like you got pulmonary edema. Then you start with the leg swelling. Then the gut starts swelling. They get dyspepsia, indigestion. Then it reaches the liver, the neck. When that happens, we say the patient is in congestive heart failure. When both the right and the left heart fail, we say the patient is in that's the only time you call it congestive heart failure. If it's only the left, you call it pulmonary edema, probably secondary to left heart failure. If it's only the right, you call it right heart failure. You don't call it congestive. The only time you call it congestive heart failure is when both right and left have failed. And like I told you earlier, the commonest cause of right heart failure is left heart failure. You got that? See, now this diagram makes sense, right? So, blood enters the heart from the lung, yada yada yada. You do leg swelling. Now you understand. You can even create your own if you want. So, the pathophysiology of heart failure also reflects in the clinical manifestation of heart failure. So when your patient has left heart failure, first thing they get is dyspnea and exertion. Dyspnea and exertion. It is usually progressive. Okay? So I can run up the stairs a dozen times. With heart failure, you start going like, I can do it 3 times. But no, I can't run, I can walk. Then after a while, you can't do it. When I was an intern, I was doing my first internship in the General Hospital. And my dad was a security guard just 6 blocks away. So he wanted to come and see me in the place where they put me. And my dad had heart failure and all kind of issues, right? I said, Dad, come up. He said, on my way. I was on the 12th floor. When he got to the 6th floor, I waited for him, I didn't see him. When he got to the 6th floor, my dad was like, I'm done, I'm not coming up anymore. Because he had hypertension and heart failure. He was sitting on the 6th floor. And he had been working all night, right? So I came down like, come on, man, it's only 6:00. He said, man, son, I can't do anymore. So I walked down with him we just hang out. He was coming to my room, but he didn't make it to my room. My dad died when I was an intern. So anyway, that was the most painful death I've ever experienced. Because you know what happened? When I graduated, my dad hugged me, right? And I said, Dad, it's going to be so hard for you to die now because I know how to fight death. He looked at me and was like, you speak like a kid. I was like, no, but I mean it, Dad. I can't control blood pressure. I can't go. One Sunday morning, man, I was on my way to take one of my patients to get eye surgery. I stopped at home to just tell him I'm on my way out of city.
Yeah.
Then he was dead on the bed. It had just happened 10 minutes ago. I was like, I couldn't see. I couldn't believe it. I was like, I'll be right back. And he went 2 hours journey to Ibadan. It was when I was coming back. I was like, oh, my dad is dead. He was 62 years old, man.
Oh, bro.
Like, my dad is dead. My dad is actually dead. And then I got home. He was still dead. Then I knew he was really dead. Oh my goodness. So when I talk about heart failure, I have a very sad story to tell about it. Very painful. It's very painful to fail when you think you should have succeeded.
Yeah.
I know what I really believe. I think God did not like when I said that I was going to fight death. I gave myself more power than I truly have. I was under the illusion that somehow, because I had graduated from medical school now, I'm going to be able to stop God from taking my dad. I really believe I misspoke. And hey, my dad died 6 months into internship, man. I didn't even get to get my license. But anyway, that is part of life. We're done with this. All right, so the first thing that happened is Disney organization. My dad got stuck on the 6th floor. This guy was a boxer. But he didn't mess with me when I was a kid because my dad would beat you up. I got into all kind of trouble because I knew my dad knew how to fight. And if you bring your dad, my dad will beat your dad. But imagine going up to 6 blocks. 6 stairs on my intern and resident dormitory. So Disney organization is a very common symptom. And then they start getting atopia. You know why they get atopia, right? Because when they lay flat, you increase blood flow to the lungs. The lungs are already congested, right? So that doesn't work. They get really sick and eating matters and everything. They wake up from bed and they have to sit up, right? To make gravity discourage pulmonary flow. So that's why they use so many pillows. Autopnea is really common in heart failure, but heart failure is not the only cause of autopnea. Remember that, don't forget it. Okay? Patients with GERD can get autopnea. Patients with, we'll talk about this morning. Pickwickian syndrome can get autopnea, right? So you just have to talk to them and find out exactly what's going on. All right? And then, what happens with autopnea, right? They get like 4 to 6 pillows and they are feeling really nice and cool and they sleep and cover their nose. And then they're sleeping, they slide little by little, little by little, and they lose that height that they have gained with the pillow because now they are at the bottom of the hip, right? And then they wake up all of a sudden because once they slide to the level of the bed, venous return increases, pulmonary edema gets worse, and they wake up with an awful sense of drowning. That awful sense of drowning is what we call the paroxysmal nocturnal dyspnea. We call it PND because it is an awful sensation. It makes the patient jump out of bed and run to any window that is open to breathe, because they actually wake up with this sense like they're drowning. It's like waterboarding in your sleep. Okay? So that happens many times in the night. So that is why It is called paroxysmal because it happens in paroxysms. Nocturnal, usually at night, but it doesn't have to be a night. If the patient is a security guard that works at night and sleeps during the day, it will happen exactly like it happened at night. But because most people don't work night shift, right? And they work day shift, so it happens mostly at night. So we call it paroxysmal nocturnal dyspnea. Very important. When you get a patient that reports PND, it is extremely important that you find out how many episodes. Because the number of episodes is a reflection of the severity of that heart failure. Okay, so pay attention to the number of episodes that the patient experiences in. Okay? And of course, if hypertension is the reason for it, there'll be elevated blood pressure. If arrhythmia, and then because of the edema in the airway becomes narrow. Okay? So remember that your airway has bronchial tubes and alveolar sacs. Right? They're long, it's a bunch of tubes with balloons on the end of them. We call them alveoli, right? When there is edema, fluid accumulates in here, right? But what is also happening is that there is mucosa is swollen on the tubes, right? Right? So all this is also filled with fluid. So this airway is narrow. Whenever airway is narrow, either because of mucosa edema or because of vasoconstriction, you're always going to get a bronchi, you're going to get a wheeze. Okay? So when you get a bronchi or a wheeze as a result of pulmonary edema, that is what we used to call cardiac asthma. Okay? Because the patient now starts with is cardiac asthma, right? You have an audible wheeze and you have an auscultatory bronchi. And then, I hope you can appreciate the fact that before you can get free fluid in the alveolar space, you probably will have had edema of the bronchioles. So generally speaking, the wheeze come before the bibasilar fine crepitations. That is, the crepitations is as a result of fluid shifting within the alveoli as it fills with air and empties in inspiration and expiration. Right? Okay. So you get rows and crackles. Then you have these abnormal heart sounds. You can get a specific heart murmur if there is a valve abnormality involved. Volume overload, you get an S3. Pressure overload, you get an S4. You know all that now, right? Good. And then you have an apical heave. That depends. Apical heave depends. If it's a diastolic dysfunction, yes, there will be an apical heave. Because remember, diastolic dysfunction is a pressure overload, right? You have a concentric hypertrophy, so the apex will be like powerful. All right? Good. All of that is only when you have oh, I think I messed with it. Okay, fine. So everything I just talked to you about is symptom and sign of left heart failure. Okay? Dyspnea, orthopnea, PND, cardiac asthma, bibasilar crackles, abdominal heart sound, yada yada yada. Left heart failure only. When the right heart begins to fail, your patient begins to have indigestion. Indigestion is from the mucosal edema in the GI tract, right? They get nausea and vomiting, not very common. When your patient with heart failure come to you complain of nausea and vomiting, they are more likely to be having digoxin toxicity than heart failure symptoms itself. Okay? So nausea and vomiting is not particularly common in heart failure. All right? Then they have abdominal distension because they can get free fluid in the abdominal cavity called ascites. Right? They get nocturia. Now you know why they get nocturia, right? Because when they sleep, the edema gets absorbed, cardiac output increases, urine formation increases, so they get comfortable edema at night, right? Then jugular venous distension with hepatojugular reflux, we talked about that earlier, right? Right? Okay, and then you have all these abnormal heart sounds from the right side, right? You can have a parasternal heave. Remember that? I told you that the ventricle that is closer to the sternum that you can feel with your bare hand on the chest is the right ventricle. So if you put your hand on the left parasternal area and you feel a heave, that is separation to the right ventricle, putting it in. And you shouldn't feel it normally. If you feel it, that is because the right ventricle is enlarged. So most of the time in exams, they will tell you there is a right parasternal heave. That is the code word for right ventricular hypertrophy. So if there's a right parasternal heave, you expect to see right ventricular hypertrophy on EKG. Okay? If there is apical heave, that is left ventricular hypertrophy. Okay? Remember that. If they tell you the apex is diffuse and weak, that tells the left ventricle is dilated. Okay? That is the code word for dilated cardiomyopathy. Okay? Just remember all those. Alright? Of course, then you get hepatomegaly because the liver is congested with blood now, right? And then you have ascites, and then you have dependent edema. Now, don't make the mistake. When you examine patients in nursing homes, I know a woman that has been in a convalescent nursing home for 6 years now, on a vent. She's been on life support for 6 years. Okay, so let me ask you, and this is the nature of patients in nursing homes, right? So if they've been lying down for 6 years, would you see pedal edema? No, you wouldn't. But you will see sacral edema, right? Because they've been lying down for months. You don't go looking for pedal edema, you won't see it. So if you're not astute, you say there is no pedal edema, so it's not congestive heart failure. No, roll her over. You see the edema in her back. It's called sacral edema. Okay? Very important, and you appreciate that.
Lawrence,
Yes.
you said the most common cause of right heart failure was left heart failure.
Yeah.
So these are just clinical features, but you wouldn't diagnose heart failure just based on clinical symptoms, right? You would need a CDK.
As a matter of fact, heart failure is a clinical diagnosis.
Okay.
Yeah.
So
You will diagnose heart failure clinically most of the time, but you will classify it with a test.
So I'm saying, if you were to see someone with dyspnea exertion, right?
Uh-huh.
And you also see indigestion not involved, you would say that they have a right heart failure as well?
No. If I have somebody with dyspnea exertion and they have nausea and vomiting,
And indigestion and all this symptoms of right heart failure as well.
well, in order for them to get right heart failure, they have to have a full-blown left heart failure. So they have to have more than dyspnea exertion. They have to have dyspnea exertion, orthopnea, right? And they have to, because remember the dyspnea exertion is due to pulmonary edema, right? Right? So they have to have orthopnea, they have some kind of PND. In that case, and I see nausea and vomiting is congestive heart failure on the pulmonary one. But just dyspnea exertion is not enough. Yeah.
Are you able to have right heart failure without left heart failure?
Yes. But that is it's a different animal. Right? So that is what you get in COPD, remember? When you have COPD and you have chronic COPD, end-stage lung disease, and then you get pulmonary hypertension, and then you stress, you get called pulmonary, exactly. That's what called pulmonary is. So you get pulmonary hypertension, you stress the right ventricle fails. That is why those patients, they can do anything. They can run up the stairs, they can do everything as their COPD allows them, but they don't get orthopnea, right? They don't get PND, and their lungs are usually clear. Because remember, if the right heart is failing, that means it can't pump blood to the lungs. So they will not get pulmonary venous congestion. You understand it? So you can definitely get right heart failure by example. That is why I separated the symptoms. So you know right heart failure versus left heart failure. And the only time you call it congestive is when there is biventricular failure, right and left. Is that clear? Good. And then this is all the symptoms of heart failure. You will see here that they talk about dilated pupils. That has nothing to do with the heart. But when your heart is failing, you're a nervous wreck. Okay, so you have the autonomic system, the sympathetic nervous system activated because you're scared, right? That's why you get all these dilated stuff. They look pale and gray, and they could be cyanotic because the heart is failing. They look pale and gray because of vasoconstriction in the skin, right? So everything else, shortness of breath and exertion, yeah. Orthopnea, crackles, cough, yes, cough because of congestion of the airway, right? And usually the sputum is what is called frothy. It's called frothy sputum. Frothy as in F-O-R-T-H-Y. So it feels like foam and water. You know when you say water? Yeah. So the sputum tends to be frothy sputum. Alright? And then that's how you also know that this is heart failure. Nausea and vomiting, like I told you, is not very common. You see it in heart failure, you should think more of reduction, dependent edema, right? So now we're turning away from calling it pedal edema. We call it dependent edema, so that you know that you will get it in the dependent area. If your patient is ambulant, you will be pedal. But if your patient is bedridden, it will be sacral. Whichever part of the body is dependent is where the edema will be. You got it? Okay. And then you get anxiety, falling O2 saturation, confusion, jugular venous distension, infarct, maybe, fatigue, for sure. S3, if volume overloaded, enlarged spleen and liver more likely, spleen sometimes. Decreased urine output, of course, if cardiac output is reduced, renal perfusion is compromised, urine formation is not going to happen, right? So they have oliguria, all right? You should be able to connect all these things. That's why you took your whole course in physiology, right? Then you get venous, jugular venous distension. And you know, you can actually measure that. And that is, did they teach you this in physical diagnosis yet?
Yeah.
Okay, so you measure the jugular venous distension, usually about 3. Anyway, you've been taught that this. You measure it from the external border with this ruler thing there. They talk about the jugular venous pressure waves too, right? Okay, so you know that not only do you have, in heart failure, you get jugular venous distension, but in addition to the venous distension, you get the venous pulsations. And the venous pulsations are actually reflections of the pressure changes within the heart. And they can give you some interesting diagnostic clues, right? So you have the A wave, you have the C wave, you have the B wave, you have the Y descent, you have the X descent. And I saw this cartoon just recently. Somebody put it together. I really like this cartoon because it talks about it very well. A wave, the rising part of it is due to atrial systole. The down part of it is atrial diastole. And remember, that is when the atria is filling. When the tricuspid valve closes, it stops the flow of blood into the ventricle and creates this up. That is, and then you talk about the wide descent because of the ventricular, when they contract down, right? And then the other valves open and the ventricular systole is go up, and then ventricular diastole. So, generally speaking, if the atria contract against an obstruction, you get a giant air wave, right? Remember the Cannon wave? Yeah. Like, okay. And then if you have tricuspid regurgitation, when blood leaks back into the neck from the left ventricle to the right ventricle, you get a giant V wave. Remember all that stuff, right? Okay. Okay, I'm glad you talked about that. That is important. And pedal edema, actually you can grade it 1 to 4 plus. Actually has meaning. You know, that's what that is. Okay? These are things I'm glad to talk about. This is what pulmonary edema looks like on chest x-ray. This is a normal chest x-ray. See how you see the air and you see the pulmonary markings, and you see how clear the costophrenic angles are, right? In pulmonary edema, there is a little bit of pleural effusion, so that angle is gone, and then you cannot make out the border of the heart because of the increased lung mark and pulmonary vascular markings. Okay? All of these white lines that makes this lung look fluffy is congested veins. Okay? So, in the emergency room or urgent care, you want to know, does this patient have heart failure? Well, it used to be just clinical diagnosis. But there are times patients can be complicated. Let me give you an example. You have a patient, an alcoholic patient, right, who's been drinking, say he's 50 years old. He's been drinking since high school, like many of them these days, right? So he's been drinking heavily for over 30 years, right? Now he's 30 years old. He has liver cirrhosis from drinking. He has alcoholic dilated cardiomyopathy, right? So this guy is going to come to you, leg swelling. You will not see hepatomegaly because the liver is shrunken and fried out. He has alcohol history, so he has dilated cardiomyopathy, and he comes swollen, JVD. What the heck is going on here? Is this cirrhosis I'm dealing with here, or is it cardiac failure? What am I dealing with here? The guy has volume overload, and because he fried his pancreas, he developed diabetes, has proteinuria, and may have nephrotic syndrome now. Yeah, good luck with that. I have a patient with nephrotic syndrome, cirrhosis, and heart failure. The guy is swollen. What am I dealing with here? Now this is where your clinical examination now go like, well, what the heck, man? You don't have to depend on blood tests. One thing you must have to call anybody congestive heart failure is volume overload. You must have volume overload. And the way we test for volume overload is we look for B-type natriuretic peptide. Remember, I told you, if BNP is elevated, the patient is volume overload. Why is that so helpful? Because in cirrhosis, you're not volume overloaded. You're swollen, but you're not volume overloaded. Because in cirrhosis, you have low albumin, right? And because you have low albumin, you're losing fluid into the extravascular space. So yeah, you're swollen, but within the blood vessels in the intravascular space, you're actually volume depleted. You understand that? So that is why BNP is so helpful. Because with BNP elevation means you are congested within your blood vessel, inside your blood vessel. It is possible to be edematous, have a lot of fluid on board, and be dehydrated or volume depleted. Because a lot of the fluid you're carrying is outside of the vascular space. We call it third spacing. Right? You heard that before?
Yeah.
Good. So, first thing you want to ensure is the patient is volume overloaded. Right? Then, you want to find out what kind of heart failure is this. You do echocardiogram. Why you do echo? You want the ejection fraction. Because you want to know, is this heart failure with reduced ejection fraction? Or is it heart failure with preserved ejection fraction? Right? Because that will help you figure out what is going on with the patient. And then the rest of your test is just routine. Right? You do a complete blood count because you want to make sure it's not anemia. Because if it's anemia and ejection fraction is normal, then you know you're dealing with, ejection fraction is high, you know you're dealing with a high output heart failure, right? Right? You do comprehensive metabolic panel because you're looking for kidney disease. Because remember, if your kidneys fail acutely, you're going to retain fluid. If you retain fluid, you're going to volume stress your heart, and that could put you into heart failure. In which case, your heart is not really failing, just an unreasonable demand in volume being placed on inside the acute renal failure. So you focus on the renal failure, and then the heart will recover. Okay, you understand that, right? Yeah. Okay. So that's why we do all these other tests. We do thyroid function test. So both hyper and hypothyroidism can cause heart problem. You do electrocardiography because you want to make sure you're not dealing with any abnormal heart rhythm. And if there is evidence for coronary angiography, and coronary ischemia, you do coronary angio. But those are routine tests. The main test that you do for heart failure is BNP or pro-BNP to show volume of balloon, and then echo to classify the heart failure. Okay? BNP is interesting, but it's not that reliable when the numbers are in between. You can get low levels in obesity, patients with diuretics, patients renin-angiotensin system inhibitors like captopril, renin inhibitors, and losartan, and all that. Those ARBs and ACE inhibitors, they will suppress your BNP. So if your patient is on captopril, you cannot rely on BNP, right? This is important. Because if your patient is on captopril, which your patient will be on if they have had a heart attack before, right? You cannot say, this is not heart failure because BNP is normal. No, you can't say that. Because your patient is on ACE. ACE inhibitors will suppress your BNP. So if you say the patient cannot have heart failure because of low BNP and you forgot that they are on ACE, you will miss heart failure. You will send the patient away from the emergency room and they will die in your parking lot. And you are in some serious trouble. Okay. And again, if your patient is an elderly patient over the age of 70, they have COPD, they have diabetes, they have kidney failure, liver failure, or they have history of heart failure, BNP will be high. So if you don't recognize those conditions and you see high BNP, you say, oh, this is heart failure, I've been to CCU. The patient goes to CCU and $5,000 later, they say, but the patient is not in heart failure. So who put the patient on CCU? I say, oh, it's Stanley. It's Stanley, why did you put the patient on CCU?
Already.
He had BNP. His BNP was 600. I said, but his COPD is diabetic. He has liver cirrhosis. Why are you doing that? You're going to take $5,000 from your paycheck. They don't do that.
No.
You know, so it's extremely important. You will overdiagnose heart failure or miss it completely if you're not aware of the kind of things that can cause increase and decrease in BNP. Right? Under normal circumstances, if your BNP is less than 100 or pro-BNP is less than 300, less likely you have heart failure. If it is more than 500 or 1800 BNP, pro-BNP respectively, you have heart failure until proven otherwise. In between those two numbers, can I just play it by ear? Okay?
Dr. Martins.
Yeah.
So does it mean that in patients who are already who have been diagnosed with heart failure and are probably on diuretics that BNP has no role?
Thank you. If your patient comes with history of heart failure and they're already been managed for heart failure, that's why we don't call them congestive heart failure. We call them congestive heart failure exacerbation. So we're not trying to diagnose them with heart failure. We're trying to just decongest and treat the heart failure. Everything I'm telling you is about a patient that is de novo heart failure. Okay? Good. Good question.
What's the alternative if you do have a patient and you do suspect heart failure, you just not do a BP or
You take BNP, but you need to take precaution.
Okay.
That's why I told you that the diagnosis of heart failure is really 100% clinical. All these tests, they help, but apart from echo to help you determine the ejection fraction and the type of heart failure, your diagnosis of heart failure is based on your hands and your brains and your eyes. Really. Right? Good. We have a classification of heart failure, two of them, American Heart and New York Heart. New York Heart Association classification is what we use the most. So that's what you get in many exams. The patient has heart failure, New York Heart Association class 2. Basically, class 1 is like our patient is able to do everything they need to do. It's not stopping them. Class 2 is, well, they are not able to do their luxury activities like jogging, playing tennis and stuff like that. Class 3 means they cannot do what they need to do for daily living. Go to work, go to the store. Class 4 means they are symptomatic at rest. Okay, so most of the patients that we should be seeing in clinic, they are class 2, 3, New York Heart Association, right? That's not what you use. All I need you to know is that A, B, C, D And 1 to 4, there are classifications, where 1 is based on symptoms, the other has a little bit more emphasis on pathology, what is causing it. The one we use the most. Because honestly, look at this American Heart Association classification. Stage A, patients are at risk for heart failure but have not developed structural heart or have no symptoms. What bullshit is this? How do I know if patient has risk and has not developed structural heart? Well, how do I know that? All I know is that the patient has no symptom, period. Because I can talk to him and I can find out, examine him. He has no symptom, no sign. So that is stage A. That is why people don't use American Heart Association classification, because it's senseless. We're talking about something to help us identify the patient and make sure we triage the patient quick. You're there talking all this nonsense, high risk for heart failure, has not developed structural heart disease. Am I going to know that in clinic? You know, so we don't use that nonsense over there. You see, we use New York Heart. But generally speaking, you can help them because they are supposed to be some smart people, right? Over here. You're supposed to help them believe that they know what they're doing. You equate stage A of American Heart to stage 1 of New York, right? B to stage 2, C to stage 3, D to stage 4, right? I just don't like American Heart Association classification because look, stage D, patient with end-stage or terminal heart failure requiring specialized treatment strategy. How am I going to know that? How am I going to know that? If I see the patient in clinic, I don't know if he's end-stage or not. I have to do tests. And if I have to do tests to figure out whether how sick the patient is, then you're no longer helping me to triage the patient. The purpose of the classification is to be able to rapidly assess the severity of heart failure and make disposition decisions. If I have to do a test or get a specialist to tell me, oh, this is end-stage heart failure, then I don't need you anymore. The decision is already made by somebody else. You see why the logic doesn't really make sense for American Heart? And that's why we use New York Heart Association. And most of the exams are going to be based on New York Heart Association class 2, 3, 4, 5, and stuff like that. You got that? Mm-hmm. All right. How do you treat? How do you treat? You know, I need to stop cursing, right? Yeah, I'm sorry. I shouldn't be doing that. I never used to do that. I guess I'm becoming more Americanized. With Trump around, everybody is feeling some something. I'm sorry. I don't like cursing in class. I don't. I really don't. Every time I do it, I hear myself like, seriously? So how do you treat this stuff? It depends on what you classify it to be. If you think your patient has high output failure, you really want to do, you see, you should flip this. With high output, what you really want to do is to treat the cause. Because remember, high output means the heart is overworking, right? So the first thing you want to do is to actually treat the cause of it. You can give the patient temporary relief with decongestive therapy. And the reason I put the congestive therapy first here is because if your patient is truly in heart failure, they have pulmonary edema and they can't breathe. So with the decongestive therapy, you can help them breathe easier and then focus on treating the cause, right? So if it is anemia, you transfuse PAC cells. Why am I not transfusing whole blood?
Because you have volume. You don't want more volume.
Thank you, good. Because with anemia, it's a chronic blood loss. If I transfuse whole volume, I will volume over a little bit hot and make them worse. They have more blood, but they're not going to feel better. They might even die while receiving the transfusion because I'm volume over it. So generally speaking, what we do is we give them PAC cells, and as the PAC cell is running, you're flogging them with Lasix. So the blood is becoming dense and better quality, and in 4 to 6 hours, you will be amazed. You'll be amazed how a patient that comes in will go and say, thanks, Doc, thank you so much. In 4 to 6 hours. I've seen that. Heart failure is an interesting condition to treat. Patients go literally from death to life. Of course, hyperthyroidism you have to treat. We'll talk about how you do it in some. Thiamine deficiency, give thiamine. Paget disease, bisphosphonate. Treat the cause. Bottom line, high output failure. Normal output failure, that is when you really, decongestion is important. And you beta block. Remember that, you beta block. Why you beta block?
Remodeling.
Because remember, it's a stiff problem, right? It's a problem with feeling. So once, if you beta block, you prolong the diastolic time. So you give the stiff heart more time to see if it will take more blood, right? So beta blockade is extremely important in patients with preserved ejection fraction. And then ultimately, you also treat the cause. If it's a valve problem, you fix it. If it's systemic hypertension, you fix it. If it's pulmonary hypertension, you fix it. How do you diagnose systemic hypertension? Ali, how do you diagnose systemic hypertension?
You need blood pressure readings.
Oh, good, with cough, right?
Yeah.
So how do you diagnose them? And how do you diagnose systemic pulmonary hypertension?
With the blood readings?
How?
So,
Pulmonary hypertension. How would you diagnose it?
so if like other therapies or treatments have failed, or
No. I'm not talking about how you evaluate it. How would you treat it? I mean, sorry, how would you diagnose it? If you think patient has pulmonary hypertension, how would you diagnose it? Systemic hypertension, you measure the cough pressure. For pulmonary hypertension, I hope you realize that you have to do right heart catheterization.
oh
Right? You realize that, right? Okay. So, because it's often asked in exams, how do you diagnose pulmonary hypertension? You have to do a right heart catheterization. The only way you measure the pulmonary arterial pressure is to put a catheter through the femoral artery, through the femoral vein, thread it to the inferior vena cava, get it into the right ventricle, and get it into the pulmonary artery orifice, and then you measure it right there. So that is the so. Even though we talk about systemic hypertension and pulmonary hypertension as both types of hypertension, one is a more invasive procedure to diagnose it. The other is a very easy routine test to diagnose it. Okay, there's a lot of difference between measuring somebody's blood pressure with a cough and stethoscope versus measuring with the right heart catheterization. Okay, right heart catheterization is done in cath lab, whereas systemic hypertension is diagnosed by MAs. Pulmonary hypertension is diagnosed by cardiologists. Don't forget that. All right. So when there is reduced ejection fraction, look at this step ladder approach. Let me just make sure that you understand everything we talked about before we got here. In high output failure, you treat the cause. You decongest as a temporary measure to help the patient breathe better, but the goal is treat the cause. You don't give digoxin, you don't do anything. You don't do after load reduction, you don't do nothing. Treat the cause and decongest. For normal output, preserved ejection fraction, you decongest and you give beta blocker. You don't do anything else. You don't give digoxin when the ejection fraction is normal. Why? It's like flogging a dead horse. I mean, the ejection fraction is normal. Why are you stimulating the heart to pump more? It's already pumping, right? So you don't use digoxin for preserved heart failure, what is called HF with preserved ejection fraction. You don't use digoxin for that. Now, the kind of heart failure you're more likely to see, the more prevalent one, is the heart failure with reduced ejection fraction. That is the real heart failure. Okay, that is the one that you really have to manage. That is the one you will manage. You will see it, believe me. Every single week of your life, you will treat ejection fraction, heart failure with reduced ejection fraction. So let's start from the beginning.
Is that the one you give digoxin to?
Yes, that's the one you give a lot of stuff to. Let's go through this staircase. The best way to treat that heart failure with reduced ejection fraction is to prevent it. Okay, that's the best thing you can do. Prevent it by controlling blood pressure, control diabetes, treat dyslipidemia, put your patient diabetic on ACE inhibitors or angiotensin AT1 blockers, right? Prevent it. That's the best thing. Okay. If you prevent it with your controlling the risk factors, and then you give them ACE inhibitors to enhance the remodeling, make sure it heals right. So you use the ACE inhibitors or AT1 blockers in all patients, beta blockers in selected patients. Again, see ACE inhibitors and beta blockers in all patients, right? So basically, in order to read this thing properly, just go from step 1, skip this nonsense over here, and go to this step over here because it's redundant in a way I don't like, right? You notice that you begin with controlling the risk factors, then you give ACE inhibitors and beta blockers, right? For reasons that you already know, remodeling and enhancing feeling, right? Now, you notice that dietary restriction and diuretics and digoxin is way up there. Why is that the case? Because that is only really needed when you have edema, when the patient is not beginning to go through into congestive heart failure, right? Okay? That's when you have to use dietary sodium restriction and diuretics and you give digoxin. That is where you will stop, right there. After that, you are going to need somebody's help. You can do cardiac resynchronization if the patient has a bundle branch block, right? You can do revascularization if there is atherosclerotic coronary artery disease. By this time, you're not just needing cardiologists, you're needing nutritionists, and you're needing all these special people that will come. And ultimately, you're going to need what is called the ventricular assist device, which is really a pump. I had a patient that was on VAD in my first class, so I brought the patient here, and people were like, oh. Yeah. I like this because the bottom line I want you to learn here is that you don't throw everything at the patient at the same time. Okay, be organized. If you know what the patient has, deal with it as the symptoms evolve. Okay, control the risk factors, give the beta blocker, give the ACE inhibitor. There is now leg swelling, indigestion, give the digoxin, give the diuretics to decongest them, and then you have ejection fraction is now 35. You decide you're going to put digoxin, then you start digoxin, right? Just be organized. Don't throw, because to start with, remember I told you, your heart failure diagnosis is clinical. So technically speaking, the only thing you can throw at that patient immediately is after EKG, beta blocker, ACE inhibitors, and diuretics. That's it. You can't do anything else until you know exactly what the ejection fraction is. Then you will now give them digoxin if ejection fraction is less than 30. Right? Okay, but let me make it a little bit more. This is just to introduce you. This is an overview. Now let's go into more specific. In terms of specific, what you're really doing for ejection and heart failure with reduced ejection fraction is two things. Only two things. No, actually three things. You're doing preload reduction, after load reduction, and positive inotropy. That's what you want to do. So you want to reduce the congestion, right? Right? You want to reduce the volume that the heart has to deal with by reducing the preload, right? And you do that with diuretics. You want to reduce the afterload. You want to reduce the force against which the heart has to pump to push blood out, right? So you reduce afterload. So you do vasodilators for that. And then you want to stimulate the heart to pump stronger and harder. That's what you do with positive inotropy, right? So what medications you use depends on where you are, who your patient is. Just know in your mind that for heart failure, congestive heart failure with reduced ejection fraction. I'm going to reduce the afterload, I'm going to reduce the preload, and I might have to put in positive inotrope. How do you reduce preload? Diuretics. You don't use, when your patient is in heart failure, it's not when you're using thiazide diuretics. Because they're given by mouth, they take forever to act. You want your patient to get better in hours, right? So this is where you use loop diuretics, Lasix, okay? Then sometimes you might even have to combine Lasix with thiazide and potassium-sparing diuretics. And whenever you use multiple diuretics that act in more than one location, that's what is called stacking. Okay? Say this patient is not responding to Lasix, I'm going to have to stack these diuretics. So you now think about one that you're going to use to block the collecting the distal convoluted tubule and the loop of Henle. So you stack it. So your patients, they will be dry. Believe me, I have seen fine crackles disappear in 2 hours in the emergency room. That's why patients go there. Because the change is so remarkable. They go in there with CHF preservation and Lasix, and they give them urine. Within 2-3 hours, they feel better. They go home. They now think that is the way their treatment should be. You need to educate the patient that that is not how it should be. Right? It's not asthma. It's only asthma you can treat like that. Heart failure needs to be more comprehensive than that. Okay? It's not emergency room treatment. All right? A bunch of guys in Morehouse came up with nitrate and hydralazine together. They call it Bidil. And that medication was really helpful, but it got really, the stuff became too expensive. Nobody's using it anymore. And it's gone. Like everything we come up with. I don't know what the problem is with that. Okay. So when you want to do afterload reduction, you can use ACE or ARBs, nitrates by infusion, and hydralazine. Okay? Yeah.
How long till, like, after you suffered an MI, how long does it take to develop heart failure?
To develop heart failure?
Yeah.
It depends. It depends. Somebody has heart failure. I'll tell you a story. How quickly you go back to heart failure depends on the patients. If your patient come in and you treat them well and you send them home and you send them to a nutritionist and they know how to watch their sodium intake, they may never come back to you. But if your patient goes home, did I tell you about my patient that was eating frozen dinners? I was in the emergency room every 2 weeks.
Yeah.
Exactly. She has heart failure, right? And every 2 weeks precisely, she was in the emergency room to be congested because she was getting frozen dinners. And because it's written healthy choice and the box is green, she thought it's healthy. Oh, the day I told her to stop eating that stuff, that was the last day she was in the emergency room. Okay, so how quickly it happens depends on who you're dealing with, who the patient is and stuff like that. Right? Excellent. So digitalization, why does Digitalis work? And by the way, you know, Digitalis is it's different from all pills because Digitalis you have to load, right? You have to calculate the loading dose and you have to load it over 24 hours, right? Generally, the loading dose in adult is 1 gram. Eh? You will kill the person. It's 1 milligram. It's 1 milligram. So what you do is you usually give 0.5 now, then you wait 8 hours, then you give the next 0.25, and then you wait another 8 hours, and then you give the remaining 0.25 in somebody with normal kidney function. If the kidney function is not normal, you give half that, okay, in 24 hours. So you have to load the vaccine. That is why we don't call it Digitalis therapy, we call it digitalization, because it's not a one-time thing, it's a process, okay? Why does it work? The reason it works is because what Digitalis does is to block the sodium-potassium exchange. So now this is where you want to stop writing and just look up. So what There are 3 pumps. Well, there are more than 3 pumps in the membrane. You know all that, right? All kind of pumps. But as far as the heart is concerned, there are 3 pumps you want to be aware of. There is the voltage-sensitive sodium calcium channel blockers, channels, and there is the sodium calcium exchange channels. But the one that is more prevalent is the sodium potassium exchange. It's common in all cells. So what digoxin does is to block this pump. By blocking this pump, sodium accumulates within the cell. When sodium accumulates within the cell, this sodium calcium exchanger cannot bring sodium in because sodium is full, the cell is full. So because it cannot bring sodium in, it can't get calcium out, so calcium accumulates. Right? The same thing happens over here. This sodium calcium voltage setting channel needs sodium to come in. Well, if this pump is blocked, sodium cannot leave. If sodium cannot leave, this sodium can come in. If this sodium can come in, this calcium so the sodium cannot come in, this calcium can't come in as well because it's a co-transporter, right? At the end of the day, what you get is increase in intracellular free calcium. That increase in intracellular free calcium is what activates your troponin myosin complex and make the contraction stronger. So because digoxin increases the contractility of the myocardium, that is what we call is a positively inotropic agent. Okay? And everything I just told you is what is on the side here. Digoxin is a glycoside. In addition of that, increase in that, decrease in the exchange. At the end of the day, what you really end up with is increased intracellular concentration of free ionic calcium that stimulate the actin myosin complex and make it contract. Okay? So that is how it works. Yes?
So where does the chronotropic component of that come from?
Well, what is chronotropy? It's increase in heart rate.
Yeah, so
it does not, digoxin does not increase your heart rate. It increases your force of contraction. Inotropy. It's a positively inotropic agent.
So only inotropic.
Only inotropic. It does not do anything with chronotropy. It does not alter the heart rate. Unless when the patient is toxic.
Oh, toxic.
Only when it's toxic, then it will slow down your heart rate. And that's not a good thing. Alright, so digoxin toxicity. How does it present? You must know this because you will treat patients with heart failure. Confusion, bradycardia, arrhythmias, SA block, loss of appetite. See what I mean? Nausea, vomiting, diarrhea, kind of rare. Vomiting is key. Palpitations because of the arrhythmias. And then when they look at light, they see this yellow halo around lights called xanthopsia. They might have blind spots. They might see snowy vision, photophobia, decreased urine output. That's not a good sign. This looks like a long list, right? You don't have to worry about it. Just remember vomiting and yellow vision and bradycardia. So your patient comes with vomiting, yellow vision, you examine them, pulse rate is bradycardia, your patient is on digoxin, you tell him to stop the digoxin, send, or the patient is stable, just stop digoxin and send to the lab for digoxin level, to measure digoxin level. And then they'll tell you, oh, it's toxic, it's not. But if your patient, you know why digoxin toxicity is so common? Because you get increased digoxin toxicity with hypokalemia, dehydration, reduced magnesium, and all these other drugs. Look, most of your patients with heart failure are on diuretics, right? So they are already at risk for hypokalemia. Most of the patients are likely to be over-diuresed. They are at risk for dehydration. Most of them will waste magnesium because that is what diuretics make the kidney tubules do, waste magnesium. That is why this is so important. You're likely to see this. Okay? Pay attention to vomiting, yellow vision, and bradycardia. They are very important signs because confusion, arrhythmia, none of those is specific. But vomiting in patients with digoxin, bradycardia, and yellow vision, you should think very seriously about digoxin, doxycycline. Okay? And then when you look at the EKG, you see prolonged QT interval. That is another way. When you have patients on digoxin, every single time you see them, do an EKG. Because prolonged QT interval is another sign of toxic levels of digoxin. Okay? And that prolonged QT interval is also associated with a very unique sagging of the ST segment. Okay? The ST segment sags in patients with DIGE toxicity. How do you manage somebody with digoxin toxicity? If it's acute, your patient comes to you within 2 hours, emergency room will give them charcoal or cholesterol to bind the digoxin from their gut and get rid of it. Okay? But if it is more than 2 hours, because how long does food stay in your stomach? It's 3 hours, right? If it's more than 3 hours, it's already gone past the stomach. There's no point to giving them charcoal and cholesterol. You give them Digibind. Digibind is really an antibody, immunoglobulin, that is produced against digoxin. Okay, and is inhuman. So what you do is you give Digibind, and Digibind will chase the digoxin in the circulation and bind it, and the macrophages will take care of it. Okay, and you give Digibind to get rid of it. Okay. Meanwhile, while you're getting the Digibind and getting approval, you can use atropine, because remember, bradycardia is about what they come with, right? You can use atropine. You can give them potassium, magnesium, and if you're in a good place, you can actually start them with temporary pacing, right? They put a temporary pacemaker. Cardiologists put temporary pacemakers all the time. It's not a big deal. Okay. Pay attention. Digibind, only when it is chronic. In acute cases, control the arrhythmia, give charcoal and cholesterol. If you cannot give charcoal or cholesterol because it'll be more than 3 hours, then you control the arrhythmias and you give Digibind. Don't forget it. Digibind.
Could you spell that?
Digi, as in digoxin bind.
Dr. Martins?
Okay. Just making sure.
How did you classify chronic?
Chronic?
After 3 hours.
The thing about it is, it is chronic if it is not under 2 hours. Because the truth is, you don't know how long it's been, right? The patient comes to you, you see a patient every 3 months, he shows up this time, now he's bradycardic, he has nausea and vomiting. Oh, you do EKG, QT is prolonged. You don't know how long it's been, but for sure it's not 2 hours, right?
Mm-hmm.
Now, remember, we said you give beta blockers, right? For somebody with heart failure. Doesn't that scare you? If somebody's left ventricle is not pumping, the patient has reduced ejection fraction, why do I want to beta blocker? You know what? There are some brave souls in healthcare. And they're brave because they use information wisely. Remember I told you that when somebody is in heart failure, they're also a nervous wreck, they're anxious. The sympathetic nervous system is like out and wild, right? Somebody figured out that maybe the patients are even sicker because they are anxious. So let's give beta blockers to suppress the sympathetic nervous system and see whether we will improve outcomes. That's what they did. And it worked. Beta blockers actually, in heart failure, improves clinical outcome. But you have to remember that your fear is not unfounded. You cannot be casual with beta blockers in somebody with heart failure. That is why you have to make sure that you give it to somebody who is compensated. That means they are not symptomatic. You cannot give it to somebody who has orthopnea, PNE, and they're actively symptomatic. Let me tell you what I mean by compensated heart failure, because I think you really need to understand it. So let's think about it. Remember I gave you that first example, right? Of heart failure, where the EDV, the end diastolic volume is 100 cc, right? So we say end diastolic volume is 100 cc, ejection fraction is 50 to 60%, right? This is a normal person. So with every ejection fraction, this person will pump out by 60 to 50, 60, right? Now, say something happened to the heart, and ejection fraction is now 20 to 30. The patient will now have to pump out only 20 to 30, 60, right? So the patient will become symptomatic, right? When the patient becomes symptomatic, the left atrium is not going to be able to empty, right? So the pulmonary veins start getting congested, right? The right ventricle is not going to be able to pump blood into the heart, right? But it's going to keep crying. The right ventricle, yeah, it's going to keep trying to pump blood to the left side through the lung. It's going to keep crying. And because it's going to keep crying, the left ventricle will keep getting dilated, right? Because it can't pump more blood, but the right ventricle keeps pushing blood to it. So it's going to keep getting dilated. Say it dilates, and now it dilates and end diastolic volume is now 200 cc because the left ventricle is now dilated. Even though the ejection fraction did not change, the amount of blood leaving the left ventricle is now normal again. Because 50% of 100 is exactly the same as 25% of 200. So even though the patient's heart did not improve, just by virtue of dilatation, with reduced ejection fraction, cardiac output is restored. The patient is at this point compensated.
How long does it take for it to get to the point of compensation? A few months? Okay.
A few months, yeah. All right. So the patient here is compensated. So they will be fine. They will be able to do what they need to do if they don't push themselves too hard. They're not going to be symptomatic. In fact, they might even be able to lie flat. They might even be able to take long walks with their dogs and their kids. That is when you say the patient is compensated. Now, if the patient goes crazy and goes and does cocaine, right? Because now he feels so good, he tells Dr. Martins, my doctor is a great doctor. He goes down and does cocaine. And then takes out his heart rhythm, and now ejection fraction now dropped to 10 to 20. Because he now suffers under heart attack. Even though it's now 200, well, 10% of 200 is not 50. Right? You will decompensate again. Right? You will decompensate again until the ventricle dilates again. It's to such an extent that this ejection fraction is able to meet You gotta calculate. You see, this is what happens to patient. Decompensation, compensation, decompensation, compensation. It doesn't have to be something bad. It could be something as simple as a compensated patient goes to a party, right? And they have, the Greek, right? They have this big pork thin fish they do, right? And they roast that big pork thing with all this salty stuff, right? Now you have somebody in compensated heart failure. They want to celebrate his recovery from heart attack. And then they bring this big old pork thing out with the broth and the pork skin all around it. This guy is heart failure, right? Compensated. He goes in there and he salt loads. Well, what is going to happen? He's going to decompensate, right? And he's going to come again with florid CHF, and you decongest him, and he goes home, and he feels better. If he stays well and doesn't do crazy stuff, he'll be fine for a long time. But if he keeps doing crazy stuff like every weekend, then he will always come back to you every 2 weeks. Until one day you will come in and he will never leave. That's the nature of the beast. Okay? So, that is what we mean by compensated heart failure. Okay? You understand it now, right? So when you are giving beta blocker, you must make sure your patient is compensated. You must start slow and you go really slow. That's why we start with metoprolol, some even 12.5 to 2.5. If you use bisoprolol, you can use 1.25. Look at the target dose. Your target is 200, but you're starting at 12.5. So you start slow and you go slow. You want the patient. Say, listen to me. I'm going to start you on some medication. You cannot do X, Y, Z. Before you do it, call me. And if I tell you not to do it and you do it, I will stop seeing you. There are times you have to have this hard talk with patients. I'm not going to sign a death certificate if you don't listen to me. And somehow people take that very seriously. It's an idle threat. Because if you're the provider, you will sign that death certificate. Right? But just the fact that you tell a patient that you will not sign a death certificate, not only do you bring the reality of their death closer, but that you will be hurt by their death, pulls on a different part of their heart, and they will respond to you differently. Okay? Extremely important that you really know how to talk compassionately. It does help in practice. Alright? So what are you going to do? Carvedilol is what we really use. Carvedilol, carvedilol, carvedilol. Why do we use carvedilol? Because it's a generalized sympathetic blocker. It blocks both the beta and the alpha receptors. So it really does knock out the sympathetic nervous system. It has the best outcome. Okay? You can use bisoprolol or metoprolol ER all you want, but you want the best outcome, use carvedilol. And there are times, remember, because hypokalemia is a problem, it predisposes patients to ditch toxicity. You want to make sure you prevent it at all costs. So you can give them aldosterone. But in addition to that, aldosterone has been found, aldosterone receptor blocker is what I mean. Aldosterone has been found to contribute to the abnormal remodeling of a damaged heart. See what it does. Aldosterone has prothrombic effect. It has vascular inflammation. It has immediate potassium loss. It causes myocardial fibrosis. It potentiates catecholamines. It causes sodium retention. It causes ventricular dysrhythmia. It causes endothelial dysfunction. All of these are effects of aldosterone. We did not know that aldosterone was doing this until we saw that when we block the effect of aldosterone, many of these things may no longer happen. We thought this was part of CHF pathophysiology, but when we are able to block aldosterone, we were able to prolong life. And like everything else, you will use aldosterone receptor antagonist only when your patient is symptomatic. If your patient is no longer symptomatic, stop it. The reason you don't want to keep giving it is because if you're giving captopril and then you're giving aldosterone receptor blocker, you're putting the patient at risk for hyperkalemia. And remember what I told you about hyperkalemia? It kills your patient in their good. Be careful with it, okay?
Hyperkalemia, you said?
Hyperkalemia, high serum potassium. Right? Okay. Diuretics will generally cause low serum potassium. And in order for us to save potassium, we give it with aldosterone, which blockers, spironolactone and all that. Now the problem with aldosterone receptor blocker is that we use spironolactone, right? But spironolactone has some hormonal side effects. In men, it causes breast pain whenever the dose is more than 25 milligrams. Aldosterone will have men will have breast pain. And men don't like talking about breast pain. Okay? I don't know, they find it very embarrassing to talk about breast pain. So some folks thought maybe we should do eplerenone. Eplerenone is more specific to the receptor, right? Something about aldosterone binds the receptor and there's a second messenger that actually brings about the effect. So eplerenone is more specific to the kidneys, right? But at the end of the day, the trial showed that eplerenone is not as effective as spironolactone. Okay, so we are back to using spironolactone now, not eplerenone. Do not use eplerenone. Okay, use spironolactone. Okay, and remember, don't go above 100 milligrams in patients with men. Okay, and use it only for patients with symptomatic, when your patient has symptoms. So you tell your patient, once your shortness of breath is gone, stop taking this one and take it only when you feel short of breath. Or if you think you're going to go out to Chinese food and eat beef and broccoli and put all those soy sauce on there, maybe you should take one spironolactone before you eat. You know what I mean? Okay. All right. Now, you will find out that you will get your patient with CHF and you will do all these things I just told you, put them on all these medications, and they will still be symptomatic. Because when they get to this point where ejection fraction is like 10%, the dilatation has limits. Once they are dilated maximally, 10% ejection fraction represents an absolute reduction in cardiac output. No medicine can make them better. Then you have to now start thinking about device therapies. There are two device therapies we use for heart failure. There is the implantable cardiovascular defibrillator called ICD. It is exactly what it is. It shocks the heart when it senses any abnormal rhythm. In all your patients with ejection fraction less than 35%, you should consider them for ICD. You know why? Because a dilated heart is a very unreliable, irritable heart. It goes into arrhythmia like that. And it turns out that ventricular arrhythmias is the commonest, is the leading cause of sudden death in patients with cardiac and with heart failure with reduced ejection fraction. So if we can prevent arrhythmias, we can actually help people live. So that is the logic behind ICD, is to prevent sudden cardiac death in patients with ejection fraction less than 35%. So in every heart failure patient that is still symptomatic on optimal medical therapy, the next step in management is the implantation of an ICD. And when you send them to cardiology, you don't say for evaluation and treatment. No, you say, I want you to see this patient for evaluation and implantation of ICD. You have to name it so they know what you're asking for. So the plan can approve that. Otherwise, if you say evaluation and treatment, they will only approve for the cardiologist to evaluate the patient. And if the cardiologist has stock in the plan, it's not going to push for ICU because that's going to cause the plan number. But if you already put there what you want, they have to deal with that. Okay? Now, there is something called cardiac resynchronization therapy device, that is CRT. Whenever your patient has prolonged QRS duration, remember that in EKG, prolonged QRS duration is supposed to come with RSR pattern, right? When there is RSR pattern in V1, you say it's a right bundle branch block, right? If it's in V6, you say it's a left bundle branch block. If you have QRS duration is prolonged, but you don't have RSR pattern, what do we call it? Intraventricular conduction defect, right? Remember that? Remember?
Yeah.
You remember that? All right. So, you know, the purpose for this resynchronization is when there is interventricular conduction defect, the heart is not pumping together, right? In order for you to really get good output from your heart, the right and left ventricles in a failing heart must contract at the same time, right? The left ventricle must push blood out, and the right ventricle must push blood at exactly the same time to get it to go properly. Especially in a failing heart, that is important. Because in a failing heart, every mil of blood misplaced is going to cause problem. What sense does it make to have left ventricle contracting with more force out of sync with the right ventricle? Does it make sense? No. You want them to contract together. That way it keeps the blood flowing and the lungs can be decongested. So whenever there is intraventricular conduction defect signaled by QRS duration of more than 120 milliseconds, it's 3 big boxes, remember? And no, 3 small boxes, right? Because the normal QRS duration is what? Less than 3 small boxes, right? So when the QRS duration is more than 120, which is like, yeah, 3 small boxes, right? Then you are suspecting that there is intraventricular conduction defect, which means there is some sort of left bundle or right bundle or both bundle blocks. In other words, you are not getting simultaneous concurrent contraction of the right and left ventricle. Rather, you're getting sequential. And in somebody with heart failure, that is a problem, right? So if you see that, you refer them for cardiac resynchronization therapy, yes.
What is causing the bundle branch? Is it the block? Is it the heart that is stretching so much that those impulses?
Part of it. It could be the heart stretching and distorting the bundles. It could also be the initial heart attack, taking out the bundle. It could be a bunch of stuff. But whenever you see it on the EKG, that patient will benefit from cardiac resynchronization. Okay, right? So this is why it works. Now, acute decompensation. I already told you about this. How do you get decompensation? Well, fluid overload. Your patient has hypertension, diabetes, they have heart failure, they have all these problems. They're supposed to be on dialysis, and now they miss their dialysis session. Well, if they have weak heart, they're going to go into heart failure, right? From volume overload, right? Or imagine, like my 75-year-old hypertensive diabetic went to the emergency room because she was having nausea and vomiting from low sodium, and the emergency room doctor just put on normal saline straight. Come on, man. She's 75 years old, she has hypertension, she has diabetes. The heart is not 57 years old, it's 75 years old heart. And you're just putting all this IV fluid in her, and they run it at 160 an hour. You know what that means? Think about it. 0.9 is 9 grams in every 100 cc, right? Normal saline is 0.9, 0.9. That is 9 grams per liter, right? When you run it at 100 cc an hour for 24 hours, what is that? That's 2.4. How many grams of sodium is that? That is over 25 grams of sodium in 24 hours. Very easily, your patient can go into the hospital for pneumonia, and some dumb doctor will just run this fluid, and next they say, oh, your mom just deteriorated. We moved her to the ICU. I'm like, what did you do? Can I see the orders for the last 24 hours? And then you see all this stupid stuff people do. They don't think. So IV fluid therapy. Salt loading, patients treat themselves too. Salt binging, like I told you. Drug induced. Oh, so my patient was itching. He has heart failure. Somebody put him on cortisone for itching and put him in heart failure. It happens, man. People do that kind of crazy stuff. Just have to know. Don't put anything past anybody. Because no matter what they have after their name, especially when they have MD, PhD, there's some dumbest clinicians around. They are good in the labs, but when it comes to bedside and patient management, they are the worst clinicians. Or somebody change your patient's medication for blood pressure from amlodipine to verapamil because the patient complained of little leg swelling. Instead of saying, oh, maybe you have heart failure. I say, oh, no. You see, that's the problem with amlodipine. It causes leg swelling. Let's stop that amlodipine and give you verapamil. You just sentence the patient to heart failure because you're going to suppress his heart with verapamil. If you had known that, all you need to do, ask this patient, when did your leg start swelling? Oh, my leg has been puffy since I started taking this medicine. And what is that medicine? Amlodipine. How long have you been taking it? 6 years. You know that is not heart failure, right? That is just that little puffiness you get with amlodipine, and the patient is fine with taking it for long. But you want to be heroic and you want to do something all the time. Then you will change the amlodipine to verapamil, and your patient has borderline cardiac status. You just put them in heart failure. Do you see how easy these things can happen? People don't mean to hurt people, but you know what? The road to hell is paved with good intentions. People get hurt. Just because you didn't mean to harm them does not mean it's okay. The bottom line is that the man died, and he should not have died. And then you have aggressive beta blockade. You can put somebody in decompensation with aggressive beta blockade. Alcohol, arrhythmias, acute hypoxia. Somebody would ask me, can go into an acute asthmatic attack, they have borderline cardiac status, they go into heart failure. Right? So you have to be careful with patients and how you treat them. How do you treat it? Hey, the same thing. Preload reduction, afterload reduction, and positive ionotropy. The only difference, now you're more aggressive. You're giving it by infusion, not pills. Okay? Very important. And Conivaptan, this ADH receptor antagonist, awfully expensive medication. I've never been able to give it to anybody. Every time I prescribe it, it gets rejected. And I argue and argue and argue and argue. They say, okay, fine, we'll approve it. And then they don't approve it. Then when I call back, they put me on hold for hours. So you know what I do? I just train my patient how to soft load and also how to cause what is called solid diuresis. I'll teach you that in, I'm not taking nephrology. I'll teach you in endocrinology. It's called solid diuresis, how you can get patient from diet to lose free water. It's just basically take a little protein. You notice if you eat beans, you drink a little water. If you eat high protein diet, you take a little water. It's called solid diuresis. It has to do with the way the body processes protein. And no matter what happens, it does not matter if you're dry and going to die. I know how to get you to pee water. Your body, I just know from diet how to knock off the ADH system in such a way that you will be able to get rid of pee water. It's a dietary manipulation. It's basically high protein diet and food restriction. Okay, but you have to kind of watch it. So, how do you treat it? Exactly what I just said. Why do you give low dose dopamine infusion? Dopamine is a crazy medication. At low dose, it does nothing but dilate the renal arteries. And you know, one of the problems with heart failure is reduced renal function because of reduced cardiac output. So if you're able to dilate the renal arteries, you are able to preserve kidney function, even though cardiac output is low, right? So we give low dose dopamine to preserve renal blood flow. And because if you can preserve renal blood flow, you promote renal diuresis, right? And sometimes when everything fails, you have to do hemodialysis. And hemodialysis not to dialyze them for toxins, but to get rid of free fluids, okay? It's called ultrafiltration. When you do hemodialysis just to get rid of fluid, it's called ultrafiltration. The machine is set in such a way that blood goes through it and it takes nothing out but fluid. Okay? That is one of the options you have. And after the reduction, Nesirtine is artificial BNP, nitroprusside, nitroglycerin, intravenous vasodilators. What you use depends on what the problem is. Okay? If your patient is having mostly right heart failure, you use vasodilators. That reduces the amount of volume the patient has to deal with. If your patient is having left heart issues, you use something like nitroprusside. It dilates the arteries more. Right? Are you all with me?
Could you repeat right heart issues for me again?
For after load reduction, remember you want to reduce the force against which the heart pumps, right? So you use nitroprusside for the arterial side, right? And then you can use nitroglycerin because it's a better venous dilator. If you use nitroglycerin, it reduces the venous return to the right heart. So it relieves the right heart. Right. Not by after the reduction, but by reducing the venous return.
Okay.
Okay? You're going to get a break after 2 months like that.
It's a lot.
It's a lot of slides.
Yeah.
Ah. Okay. Those people really took some time away from us. All right. Okay. Okay. Device therapy, decompensation. Okay. Okay, fine, get a break. 5 minutes though. End stage heart failure. In other words, you are losing your patient. What then can you do? I like this diagram because it's really very good. I put in some things there. So the first thing you ask yourself is, does this patient have a disease that I can treat and get rid of his heart failure? Is this a correctable cause for this end-stage heart failure? If your answer is yes, then you're good. You just do what you need to do. Refer them for garbage. They can use bare metal or drug-eluting stent, whatever. PCI, push for it, they can get it and they will be fine. Because the good thing is that once you restore the blood flow to the heart recovers. Okay? Now, if there is no correctable cause, you ask yourself, are my therapies optimal? Is the patient on maximum dose of beta blocker that they can tolerate? Is my patient on ACE inhibitors? Am I diuresing them properly? Am I stacking the diuretics if I have to make sure the patient is diuresed? If your answer is yes and the symptoms is persisting, then you want to send them for CRT, the cardiac resynchronization therapy, right? How would you know that they will benefit? You do an EKG, and if the KRS is prolonged beyond 120 milliseconds, then you know they will benefit from CRT. If they are on CRT and the symptom is persisting, you're really cutting it close now. You have to now begin to get them to get on the list for heart transplant. So while they're waiting for heart transplant, there are something called bridge to transplantation therapy. They're called ventricular assist device. That's what VAD is, ventricular assist device. These are actually artificial pumps. They run on batteries and they assist the ventricles to push blood around. So basically the patient is carrying an extracorporeal device that blood is flowing through, that is pushing that blood, assisting the ventricle. Okay? If your patient is never going to get heart transplant because they are coming to you from Burundi, then your VAD becomes destination therapy. But if they are in West, they are in South Central and they have good plan, you can plug them to UCLA, then your VAD becomes bridge to transplantation. How do you know when your patient is getting close to end stage heart failure? When their extremities begin to get cold. Their pulse pressure begins to be narrow. So blood pressure is now looking like 90/70, 100/80. Pulse pressure is narrow. And serum sodium is low. PUA creatinine is high because they are not able to maintain renal perfusion. That is when you know your patient is getting close to end stage. That patient is not going to be around for much longer if they don't get a heart transplant. Okay? This is a ventricular assist device. They call it LVAD. It is called LVAD if it's assisting the left ventricle. It is called RVAD if it's assisting the right ventricle. It is called BVAD if it's assisting both ventricles, but it's an LVAD. Believe me, this stuff runs on car batteries. And patients have been killed because somebody goes and snatches their battery. People do crazy stuff. Believe me, they do. I don't know. Anyway, so this is what it looks like, right? I had a patient here with this one time. I was talking to him, see if he can come around again. He enjoys talking about it. He was on the radio talking about this stuff. So basically, you put this thing that looks like a tube and it's a needle, plug it into the aorta, and plug this one into inside the left ventricle. So blood comes through here. And this is it's basically like a windmill rolling on the battery and pushing the blood through from the left to the aorta. It's called LVAD. They have to be on anticoagulation, right? And they carry all kind of crazy alarms, right? Crazy alarms. Plug to their phone will ring crazy. And sometimes patient is at home and the LVAD company will call. So your battery has only 1 bar left. Change the battery now. Because they have all this remote monitoring for these patients. So they can know when the patient is in trouble. It's nice to be in America. Okay, heart transplant. That's the ultimate. If you can get it. So you get a diseased donor heart and you plug it. You don't remove the old heart. Usually they just transpose the vessels into the implanted heart and leave it there. Okay? A lot of problems. Not everybody can get heart transplant. There are some absolute contraindications. Limited life expectancy. If somebody is not expected to live more than 5 years, why do you want to give them a heart transplant? You know? You might even end up killing them on the table there. If they have irreversible pulmonary hypertension, well, if the pulmonary hypertension damage the first heart, treat the pulmonary hypertension. Because if you put a new heart there, you will get killed by that same pulmonary hypertension. Okay? Severe systemic cerebrovascular disease. Somebody has multiple strokes, demented. Why do you want to give them a heart transplant? Seriously, I mean, come on, man, this is not happening. We're all going to die here. So why are you wasting people's time on this horrible planning? Somebody has multiple strokes. They are demented. They have a heart failure. You want to give them a heart transplant too? So they can live with 2 more, 3 years of misery? I mean, counsel people correctly. This is not heaven. This is still earth. Everybody here will die. And so it does sometimes, it's not how long you live, it's how well you live. Even though I'm not an advocate of people making judgment on people's quality of life, there are times you have to face reality. That this is reality. This is not, life is not supposed to be like this. We need to start cutting back on heroic measures and let people live as long as they're supposed to live, regardless. And there are some relative contraindications like cancers, mobilities, uncontrolled diabetes, liver failure, renal failure. No cardiothoracic surgeon will touch you. If you have any of these, they won't even come here. Like, go get this one fixed first. All right. Again, artificial heart is equivalent to ventricular assist device. Again, it's a bridge to therapy. So this is when you actually, the heart is now like dead. You know, ventricular assist devices require your ventricle to be working a little. When your ventricles are dead, like they're not, like ejection fraction is not like 2-3%, right? You know, you don't need airbag, you need artificial heart. Again, it's like airbag, and this now you have to want to pump blood from the right and the other from the left and put it into the pulmonary artery and the aorta. Again, it's a bridge to heart transplantation. These are not destination therapies for normal people. Okay? They are things you put patients on to hold them over while they are waiting for a heart. Okay? And now you know what people are doing, right? They're killing people all over the place and smuggling and cutting them open to rip out their hearts so they can go sell to organ transplant people. It happened in Russia, India, Africa. They have trouble because they can't get the heart out. It's a little bit more difficult for you to get somebody's heart out in Africa. Just because you have to go through customs. They always screen your bag for everything. How would you get the heart out? But you can get it from Mexico because it can come through the border or fly in a private jet. They do all kinds of crazy stuff now. This world is going crazy, man. Okay, so that is all about left heart failure. Let's talk about right heart quickly. We'll just dismiss it very quickly. We already talked about it. Right heart failure is very different from left heart failure in terms of treatment. And the peculiarities are all on this slide. The first thing I want you to know is the commonest cause of right heart failure is left heart failure, right? Now, remember, in left heart failure, I told you, you want to decongest, right? You want to reduce preload. In right heart failure, because you know what? When the right heart fails acutely, when it's not pumping blood, what you want to do is to give IV fluid to put a lot more volume in it, and hopefully you feel that with the volume, you can push some volume through the lungs to the left side. Okay? So you don't reduce preload when somebody's right heart is failing acutely. Please understand me very well. If you have acute right heart failure, say somebody has inferior myocardial infarction, myocardial infarction, yes, and that affects the right heart, and the right heart fails, and they become edematous. That's what you have. Not even shortness of breath. You have edema. What you want to do is IV fluid until you get the wedge pressure high. Once you give them enough fluid and the wedge pressure is high and they're not improving, then you begin to do afterload reduction acutely. So that is why they will test you all the time in exams. Right heart failure, first treatment, IV fluid, IV fluid, IV fluid. Because that is counterintuitive, right? Because in left heart failure, we're talking about decongestion. But in acute right heart failure, oh yes, IV fluid, until the wedge pressure is normal. Meaning enough blood is now getting to the left side. Remember, I keep saying acute right heart failure, because in chronic right heart failure, treatment is decongestion. Okay? In chronic right heart failure, the treatment is decongestion. Keyword, chronic. Okay, you got that? Okay. So that is the peculiarity for preload. After load reduction is always going to work. And most of the time you treat the cause. If you see COPD, control it and you'll be fine. You can also give digoxin if you want, but rarely would you need that. There are devices that can, RVAD is also available, and you can actually use extracorporeal membrane oxygenation, because remember, when the right heart fails, what it really means is that blood cannot go through the lungs to get oxygenated, because the right ventricle is the one that is responsible for pushing blood through the lungs. So when the right heart is failing, that means oxygenation of blood is not happening. That is why we use extracorporeal membrane oxygenation. It's like dialysis, but only this time you're adding oxygen to the blood as it's going through that device. Okay? You got that? Is it confusing? Okay, please don't forget. Right heart failure, acute, IV fluid, IV fluid, IV fluid. Chronic, decongestion, decongestion, decongestion. Very important. So this is exactly what I was talking about here, right? Acute right heart failure, preload optimization, right? Hypovolemia, IV fluid, IV fluid, IV fluid. Hypovolemia means entering in some chronic cases, then you can diurese at that time. The goal is to keep your eye on the central venous pressure. Keep your eye on the central venous pressure. Right heart failure, IV fluid, IV fluid, IV fluid, until the central venous pressure or wedge pressure is normal, right? Then you optimize afterload like everything else that we talked about. Don't worry about all this PEEP and all this crap. We'll talk about that in pulmonology lecture. We'll talk about the critical care lectures. All right, I've told you everything I need to know here about right heart failure. Please don't get confused.
Dr. Martin.
Yes.
Acuteness of chronicity, is that time bound?
Actually, the difference between acute and chronic is really, it's not time, it's the CVP. When the right heart fails acutely, CVP drops, okay? Because blood is not going to flow. When your CVP rises to normal, that means the right heart has failed for long enough for venous return to actually bring up the CVP. You're already getting congested. Let me say that again. When the right heart fails, blood doesn't flow to the lungs. So the pulmonary wedge pressure is very low, right? So what we normally do is to measure the pulmonary wedge pressure, and we give IV fluids until the pulmonary wedge pressure is normal. When the pulmonary wedge pressure is normal and the patient is still ballooning and swelling, then you manage with diuretics, and you moderate your diuretic therapy by keeping your eye on the wedge. That is really the ideal situation. The reality is that many places you don't know how to do wedge. Wedge has to be done in an ICU setting. So people have to rely on CVP, right? Central venous pressure, the neck pressure. And that is not really reliable, because that goes up whenever the right heart fails. That will be high, right? So in that case, then you begin to use some element of time to determine chronicity versus acuity. But in reality, when I say acute and chronic right heart failure, I'm not really talking about time. I'm talking about wedge, the pulmonary wedge pressure. And I will explain that in our next set of talks. Okay, I know you don't understand a lot of what I just said now, but it will become clear in my next couple of slides. But are you all clear about left heart failure? And you know about those device therapies, right? You know when to send your patient for ICD. and you know when to do resynchronization therapy, right? Right? Good. All right. Any questions? All right, I'm going to dash through circulatory shock. What is shock? Circulatory shock, a characteristic failure of the circulatory system to maintain adequate perfusion of the peripheral tissues, marked by a low blood pressure, as well as clinical and laboratory evidence of low tissue perfusion. Too much grammar. What is it saying? Bottom line there is that if you have shock, you have to have low cardiac output and evidence that the periphery is starving. They are not getting enough blood. So you have to show clinical and laboratory evidence of peripheral hypoperfusion. Okay? Remember that when somebody is in heart failure, they are not showing evidence of hypoperfusion until it gets to the end stage when the feet get cold and kidneys back up and stuff like that. Shock is low blood pressure plus evidence of peripheral hypoperfusion. The commonest mistake people make, especially in exam, is for you not to be able to tell the difference between hypotension and cardiovascular collapse. Cardiovascular collapse is another name for shock or circulatory shock. The difference is, if my blood pressure is 60/40, that is pretty low. But if I'm not tachycardic and my lactic acid level is not elevated, I'm not clammy, I'm not altered, I'm not sweaty, I'm just hypotensive. Somehow my body is able to cope with that low blood pressure. But if my blood pressure is 90/60 and I am sweaty, I'm clammy, I'm altered, I'm in shock. So shock or cardiovascular collapse is hypotension plus evidence of peripheral tissue hypoperfusion. Do you understand that? Good. Remember, in heart failure, your blood pressure is normal. Okay? So I don't want you to ever get confused between heart failure, hypotension, and shock. In heart failure, cardiac output is low. When your patient is alert, they are short of breath, but they're alert, they're oriented, they are not sweaty, they are not clammy. In hypotension, the patient may be dizzy when they get up, but they are not short of breath, they are not sweaty, they are not clammy. In shock, your patient is hypotensive and plus. They're cold, they're clammy, they're altered, and when you measure lactic acid level, it's elevated. Don't get confused. Heart failure, hypertension, and shock are three different things. That is why this definition is long, because it tries to distinguish shock from heart failure and hypertension. It says it's a failure of circulatory system to maintain adequate perfusion. It did not discuss it in terms of cardiac output. Remember, for heart failure, we tie the definition to cardiac output. But here it is just adequate perfusion. And it is marked by low blood pressure. I didn't stop there. Low blood pressure as well as. So shock is hypotension plus, not just hypotension. You got that? Excellent. So what are the types of shock? There are 4 basic types of shock. There is distributive shock, there is hypovolemic shock, there is cardiogenic shock, and there is obstructive shock. Now let's talk about distributive shock. Distributive shock is when the blood volume is redistributed and preferring to stay in the blood vessels than come to the heart. So when you have gram-negative sepsis, and the bacteria is releasing a lot of toxins that is causing both arterial and venous dilatation. You know what I would do, right? When you have arterial dilatation, blood will be easy. It will be easy for blood to lift the left ventricle, right? Because the arteries are dilated. But at the same time, the veins are dilated. So no blood is coming to the heart because they are going to stay in the veins. Venous capacitance increases, peripheral resistance reduces. So blood volume is shifted away from the heart. How can it pump it? And because it's not pumping it, the patient will show evidence of hypoxia. Tissue hypoxia will set in. That is what is called a distributive shock. It is commonly seen in sepsis. It can also be seen in anaphylaxis. And there is a portion of it called the neurogenic cause of it, where the autonomic nervous system just goes crazy and reduces tone in all the blood vessels, arteries, and veins. So keeping blood away from the heart. Okay? So that is distributive shock. Then there is hypovolemic shock. Well, that is due to low blood volume. You're bleeding, you're vomiting, you're having diarrhea, you're losing blood volume. It could be acute blood loss, it could be fluid loss, it could be third spacing. However it is happening, you're losing volume from within the intravascular space. That's the bottom line. Okay? And you're losing it in so much quantity that it is not only decreasing your blood pressure, but it's making you altered, sweaty, clammy, with evidence of tissue hypoperfusion. It is the evidence of tissue hypoperfusion that makes it shock. You don't find that in heart failure, and you don't find that in hypotension. Okay? And now what is cardiogenic shock? Well, it is cardiogenic shock when shock is due to heart not working. So let me ask you a question. If your patient with heart failure develops cold, clammy extremities and becomes sweaty and is now drowsy, is that still heart failure? Thank you, exactly. So most of the time, patients that go into cardiogenic shock are heart failure patients with decompensation and end-stage heart failure. Okay? You got that? You as a clinician must be able to tell when your patient is heart failure and when your patient is in cardiogenic shock. Blood pressure is normal in all heart failures. When blood pressure drops in heart failure and there is evidence of peripheral tissue hypoperfusion, like the patient becomes clammy, cold, sweaty, altered, that is no longer heart failure. Why is it important to make this distinction? Because shock is a medical emergency. You call 911. You don't do nothing else. You call 911 and get that patient out to the emergency room and the ICU as soon as possible. Okay? That's why I'm emphasizing this. Okay, that's cardiogenic shock. And then you have obstructive shock. Obstructive shock is exactly what it says, obstruction to blood flow. Usually due to pulmonary embolism, cardiac tamponade, or tension pneumothorax. It's something interfering with the flow of blood from the right to the left ventricle. Most commonly, pulmonary embolism. Okay, you got that?
Yeah.
So those are the four types of shock: obstructive, cardiogenic, hypovolemic, and distributive. That is the description. Those are the causes of it. Now, let me again say everything I've said in a different way. So, you see somebody with hypotension. The first question you want to ask yourself is this shock or is it not shock? What do? You look for signs of tissue hypoperfusion. What are those signs? Altered mental status, mottled clammy skin, kidney oliguria. These are evidence that of hypoperfusion. Tachycardia and elevated blood lactate level. That means the body is switching from aerobic to anaerobic metabolism. So it's now using more of the lactic acid, glycolytic pathway, because you can't do the TCA cycle because it doesn't have enough oxygen, right? So lactic acid accumulates. If you have hypotension with all of this, your patient is in shock. If you have hypotension and none of this, it's just chronic hypertension. Okay? It's not shock. So now when you say your patient is in shock, what do you want to do? The first thing you want to do is assess the mixed venous O2. You know what is called mixed venous O2? You see, when you do ABG, you get arterial O2, right? When you do, you get blood from the central venous veins, you only really get blood from the what? Inferior vena cava, right? When you want to really know what the mixed venous O2, you get the sampling where the superior vena cava and inferior vena cava have already emptied and the blood is thoroughly mixed in the right ventricle and is on its way out to the lungs. That blood in the left ventricle, when you measure the oxygen content of that blood in the right ventricle, after blood has returned to the right atrium from the superior vena cava and inferior vena cava and thoroughly mixed within the right ventricle, the oxygen saturation you get at that point is called the mixed venous O2. It's the most reliable index of oxygenation in the body. Okay? So, you look at that. If that is normal, if your patient is in shock and the mixed venous O2 is normal, only one thing can cause that: distributive shock. Because remember, in distributive shock, the problem is that blood is fine, but it's preferring to stay away from the heart. So it's still getting oxygenated and everything, but more of it is staying in the peripheral circulation than in the central circulation, right? Remember what I told you in cardiovascular physiology, that 2/3 of your blood volume is inside the blood vessel is actually on the venous side, right? Good. And 1/3 is on the arterial side, right? In distributive shock, even more like 90% is in the venous and the arterial side, right? And only 10% is central, right? So this oxygenation is still going fine. It's just that it's staying away from the heart. Okay? That's why it's called distributive shock. Am I communicating this correctly? Okay. So you do mixed venous O2. That is normal or high. Only one thing can cause that: distributive shock. Now, if mixed venous O2 is low, you now check CVP, central venous pressure. If central venous pressure is low, that means the patient is bleeding, right? Because central venous pressure tells you how much volume is coming to the right side, and that comes only from the body. If the blood is going somewhere else and not coming back to the heart, that is hypovolemic shock, right? If your central venous pressure is high, then that means, okay, the patient is not bleeding because blood is coming to the heart. Then the problem has to be obstructive or cardiogenic. You got that? It is extremely important that you understand how to utilize mixed venous O2 and CVP to figure out which type of shock your patient has. It is almost impossible for you to tell cardiogenic shock from obstructive shock with CVP, because both of them, CVP is high in obstructive shock and CVP is low. CVP is high in both obstructive and cardiogenic shock. Okay, in both of them. You cannot use CBP to tell them apart. Okay, you have to use echocardiogram or someone else's system to figure that out. But we'll talk about that later on. All I need you to know right now is that hypotension with signs of hypoperfusion is what defines shock. And how do you begin to differentiate it? Look at the mid-venous O2 and the CVP. Mid-venous O2 is normal, you are dealing with distributive shock. If your CVP is low, it's hypovolemic shock. If your CVP is high, it could be cardiogenic or obstructive. Because that means blood is getting to the heart, but it's not getting past the heart. Right? And the obstruction could be in the lungs, or it could be in the left ventricle itself. Which one would you see the most in practice? Distributive septic. Okay? It's the commonest. 62%, 2/3 of all shocks that you will see in practice are distributive shock. Sepsis. So these are ICU type cases. Okay? So now, because you cannot use CVP to tell cardiogenic shock from obstructive shock, almost all the time, when you have a patient in shock, where CVP is high, you have to send the patient on to the CCU because they have to do right heart catheterization. Okay? And when they do right heart catheterization, they put the catheter in the femoral artery and they thread it up. No, why do I keep saying femoral artery? In the femoral vein, thread it up to the, depending on how they go, they can go from above. Most of the time we go from the subclavian, right? And they get into the right atrium, and you can see the pressures. And then they get into the right ventricle. The way they know where they are is the sensor at the tip of the catheter records the pressure changes. So in the atrium, they see the A and B waves, right? They know they're in the atrium. Then they keep, because they depend on the flow of blood to carry the tip of the catheter, because it has a little tip, right? And it just floats on in circulation. So when they see this recording, they know they're in the atrium, and they keep advancing it. When they hit the right ventricle, the pattern changes. I said, now we're in the right ventricle. And they keep going until they now go through. When they now go into the pulmonary artery, the veins begin to look like they look in the right atrium because there is no valve between the pulmonary veins and the left atrium. So the pressure that you're actually looking at in the pulmonary artery is a reflection from the left atrium. You got that? Okay. So when now they are in the pulmonary artery and they are registering this, that is when they now inflate the balloon. Okay? So now they are out of the right ventricle, they are in the pulmonary artery, the catheter is here, right? And they are recording that wave pattern that is telling them that we are now in the pulmonary artery. And the reason it looks like it looked when they were in the right atrium is because in the pulmonary artery, they are already gone past the pulmonary valve, right? So what they are sensing here is the back pressure from the left atrium. Okay? Now, what they now do is they now inflate the balloon. When they inflate the balloon, there is a sensor here that will now sense the back pressure on that balloon. That pressure that is sensed when that pulmonary artery is occluded is what's called wedge pressure. It's an index of the left atrial volume. You got that? Okay, so you go from the vena cava into the right atrium, your balloon floats into the left ventricle, then it floats into it goes into the right ventricle, then it goes into the pulmonary artery, right? And then you keep going until you get into a main pulmonary artery, right? And then you inflate your balloon. When you inflate your balloon, the pressure in the back here is what you're measuring. Because you're wedging the circulation, right? With your balloon, you're wedging the circulation. To wedge something is to block it, right? So when you wedge it, the pressure against the balloon is now called the pulmonary wedge pressure. It's a reflection of the amount of pressure in the left atrium. That is why the waves look like they look in the right atrium. Because there is no valve between the pulmonary veins and the left atrium. There's no valve there. It's a continuous pool of blood. So the pressure changes in the left atrium are reflected in the wedge. Why is this important that you understand this particular sequence? Because this is the only way you're going to be able to tell cardiogenic shock from obstructive shock. Because in cardiogenic shock, the wedge will be high. Right? The wedge will be high because in cardiogenic shock, the left ventricle is not able to pump. And because it's not able to pump, the left atrium can't empty. And if the left atrium cannot empty, then the veins can't empty. If the veins can't empty, they get distended and congested, and pressure backs off. And that back pressure is going to be measured as a high pulmonary wedge. So when there is a high pulmonary wedge, that means the heart is failing. That's a cardiogenic shock. When there is a low pulmonary wedge, that means it's an obstructive shock. That means it's a pulmonary embolism or something. You got that?
Wait, say that last part again, sorry.
If the wedge is high, that means a cardiogenic shock. If wedge is low or normal, that means it's an obstructive shock. Remember, we have been able to figure out distributive versus hypovolemic earlier on from this venous O2 and CVP, right? The only two that we are not able to use CVP to differentiate is cardiogenic and obstructive. But now wedge can help us with that. So if we do the cardiac catheterization and wedge is high, that is cardiogenic shock. Wedge is low, is obstructive shock. Got that? Excellent. So let's do some exercise. All right, so this is what I've been talking to you about. So these are the shock states, right? Hypovolemic shock, obstructive shock, cardiogenic shock, distributive shock. So in hypovolemic shock, CVP is low because volume is being lost. Of course, wedge pressure will be low because blood is not coming to the heart. Cardiac output will be low, and pulmonary vascular resistance will be normal, but the systemic vascular resistance will be high because with low cardiac output, the body will try to respond by increasing the systemic vascular resistance with vasoconstriction, right? So you end up with low CVP, low wedge, low cardiac output, normal pulmonary vascular resistance because it has nothing to do with the lungs, but high systemic vascular resistance. You got that?
Yes.
Okay, now let's talk about obstructive. If the obstruction is due to pulmonary embolism, what will happen? You will strain the right heart, so CVP will be high, but wedge will be low, right? Cardiac output will be low because there is a block. Pulmonary vascular resistance will be high because of the embolus blocking the pulmonary blood vessels. And because you are compromising cardiac output, systemic vascular resistance will be high. Are you able to follow me?
Here we go.
When you have pulmonary embolism, you are going to strain the right heart, right? And because you're going to strain the right heart, central venous pressure will be high in the neck. For wedge will be low. Because remember, wedge measures the reflection from the left atrium. If you have pulmonary embolism, blood is not getting to the left atrium. It's getting blocked inside the lung. So that will be reflected as a low wedge, right? And because blood is not getting through the lungs, cardiac output will be low. Right? Because it's getting blocked in the lungs. And because the obstruction is inside the lung, the pulmonary vascular resistance will be high because there is an intrapulmonary obstruction. Right? And because that intrapulmonary obstruction is compromising cardiac output, the autonomic nervous system or sympathetic nervous system will increase the systemic vascular resistance with vasoconstriction, trying to make up for what is going on. Right? If the obstruction is due to tamponade, it's a different story. If it is due to tamponade, CVP will be high because you're again restricting the right ventricle, right? For wedge will be high. You know why wedge will be high, right? Because in tamponade, you're putting pressure on both the right ventricle and the left ventricle. So not only isn't the right ventricle able to receive blood, the left ventricle is also not able to receive blood because it's a tamponade. There is pressure around both of them. So because there is pressure around both the right and left ventricle, both the right atrium and the left atrium are not able to empty. If they're not able to empty, they will be congested. And if they're congested, both wedge and CVP will be elevated. You're tired. So you're not able to follow. Like, goodness, I should have not done this lecture now. But don't worry, some exercise and practice will make it clear. Now, so that is obstructive. Let's talk about cardiogenic. It's very simple to see cardiogenic. In cardiogenic, the heart is really filling. So wedge, CVP is high, wedge is high, cardiac output is low, pulmonary vascular resistance is normal, systemic vascular resistance is high. You can understand why that is the case. Right? In distributive shock, look at what is happening. This is a distributive shock. CVP is low because blood is staying away from the heart. It's not coming. The veins are dilated, venous capacitance is high, peripheral distance is low because the veins and the arteries are dilated. So both the CVP, the wedge, and the systemic vascular resistance and the pulmonary vascular resistance, they are all low. And the heart is kicking its own, trying its own best to keep up by increasing the cardiac output. So in distributive shock, cardiac output is actually high, and yet the patient is in shock. The only time in distributive shock that cardiac output is not high is when it is neurogenic. And that is because you paralyze the nervous communication needed to make that happen. Okay? You're tired.
Dr. Martins,
Yes.
could you explain to me the wedge between pulmonary embolism versus the tamponade? Because I understand the tamponade is like pressure on both
You
ventricles.
remember tamponade, right?
Yeah, it's pressure on both
Tamponade
ventricles.
is when the right and left ventricle are subject to a common pressure that is compressing them.
I got that one.
Pulmonary embolism is when there is a clot in the pulmonary circulation, the artery. Okay? So, if there is pressure on both the right and left ventricles, that means both the right atrium and the left atrium can't empty.
Yeah.
So they will both be congested. The congestion of the right atrium will be reflected as an elevated CVP. The congestion of the left atrium will be reflected as an elevated wedge. Because it will back into the venous circulation and be reflected in the wedge pressure in the pulmonary artery.
Okay.
You got it?
I got it.
Excellent. Okay. And that is just the opposite. The only difference between that pulmonary embolism and tamponade is that wedge is now low in pulmonary embolism.
Yeah.
You got that?
Yeah.
Okay. Some practice will make it clear, I'm sure. I just want to make sure I get to it before. Okay, so these are the normal parameters for stroke index, stroke volume. Most of the time they will give you this. They will either tell you it's high, it's low, or they will give you a number and put the normal in parentheses. Okay, hydrogen shock. Maintain cardiac output of tissue perfusion. That's it. How do you do that? IV fluids. If somebody is bleeding blood, you give them blood. You don't give them PRBC, Pacrixial, if it's acute blood loss. You know that, right? So you give them what they're bleeding. Acute blood loss, whole blood, chronic blood loss, PAC cells. You can use colloid if they are third spacing. Crystalloid as saline solutions. We used to use hypertonic, but nobody uses it anymore. Causes more problems than help us. We use isotonic or hypotonic. 0.9 is normal saline, is isotonic. Isotonic means it's of the same osmolality as serum. Okay? Then hypotonic is for free water deficit. D5W is what we use. How fast do you administer it? As fast as you can. So most of the time, we administer it through central lines. Okay, through central lines. And we use large gauge needle, 14 to 16 gauge needles. And sometimes you have to use a pump. And if you're in a place where you don't have pumps, you know how you can do it? You put a blood pressure cuff around the bag and inflate the cuff to squeeze it through. Okay, that's how you. So basically, in shock, it's an emergency. You want to replace the volume, right? And then after you are sure that you have replaced the volume and that wedge is normal. Wedge is normal means the left atrium has enough blood. Okay, that is what a normal wedge means. It makes no sense for you to give somebody vasoconstrictors when there isn't adequate volume. You're making the blood vessels contract an empty space. That is not going to help. The only time vasoconstrictors help is when the tank is full. So you have to give the patient IV fluids until the pulmonary wedge pressure is normal, 8 to 10, or 8 to 12, right? When the pulmonary wedge pressure is normal, that is when you're sure, yes, the tank is full. The tank is the left atrium. Okay? Once you know the tank is full, now you can use vasoconstrictors and your patient will live. Okay? So you use cardiovascular medication when the tank is full. You get IV fluids to get the tank to be full. Vasopressors, you can use norepinephrine, you can use epinephrine, you can use dopamine. It depends on what the underlying cause is and who your patient is. Norepinephrine is a stronger alpha stimulant than a beta stimulant, so it is easier on the heart. You have an elderly patient with hypertension, with diabetes for a long time, you're not sure how strong the heart is, and she's in shock, you're better off with norepinephrine. Now you have epinephrine. It's a stronger beta than alpha receptor stimulant at low doses. So it's harder on the heart. You have a younger patient, you can use epinephrine, right? Dopamine is a beta stimulant at low dose and alpha receptor stimulant at high dose. So we tend to use low dose dopamine infusions to keep the renal arteries open, to preserve the kidneys. Okay, because you know acute tubular necrosis with renal hypoperfusion is a bad thing. Many, many times it may not even be reversible. So we use dopamine to keep the renal arteries open, right? Now, we use digoxin as an inotropic agent in patients with heart failure, but we use dobutamine as the inotropic agent in patients with shock. Okay? Dobutamine. And there are these new medications, milrinone and enoximone. They are both for the STS3 inhibitors. They are available, but people still use a lot of dobutamine. But bottom line is that you're going to use vasopressors and inotropic agents after you're sure that the tank is full. You got that? Okay. So, again, this is just another slide to show you how to differentiate between hypotension and shock. So somebody has a blood pressure 90/65, and you give them crystalloid, you challenge them, and their lactic acid level is still high. That is shock right there. Okay? Then when you say somebody is in shock, immediately you want to see what is their CVP. Okay, you give them IV fluid, and you monitor CVP. For as long as CVP is less than 8, tank is not full. You keep giving them IV fluid until you get you keep giving them IV fluid and you monitor the mean arterial pressure, right? Once you give them enough IV fluid to get the CVP to normal, right? Tank is full now, right? And then their blood pressure is still low, right? So CVP is normal, you show the tank is full, but blood pressure is still low. You measure the mean arterial blood pressure is still low. Only then would you give vasopressors. You got that? Then you give vasopressors and you keep monitoring the blood pressure. Now blood pressure is fine. You want to make sure that circulation is okay now, but is oxygen delivery adequate? Now you measure the mixed venous O2. If mixed venous O2 is less than 70, that means yes, blood is circulating, but the blood that is circulating is junk blood. It doesn't have enough hemoglobin. Then you can give them transfusion, right? And then you keep monitoring this mixed venous O2. Once mixed venous O2 is more than 70%, you have achieved your goal. That is when you're home and dry. Okay? It looks like a lot of information is nothing. Just stop writing and listen. Think about it. Somebody is in shock. Blood pressure is low. They're not perfusing. First thing you want to know is the patient bleeding? If they're bleeding, the CVP will be low. Where to be low? Because they're bleeding out. Right? That's simple. Now, if they're bleeding but they're warm, they are in shock but they're warm, well, that is because more blood is staying in the periphery. That's why we call distributive shock warm shock. Right? The blood is staying in the periphery instead of coming to the heart. How would you know that? When you look at the CVP, it will be low. Wedge also will be low. But the systemic vascular resistance will be high because cardiac output is low. Right? Now, if it is cardiogenic shock, well, CVP will be high. Once, the first thing, there are 4 types of shocks. Cardiogenic, obstructive, distributive, and hypovolemic. CVP divides them into 2 groups for you. CVP is normal, distributive. CVP is low, hypovolemic. CVP is high, is either cardiogenic or obstructive. Look at wedge. Is wedge normal? If wedge is normal, then if wedge is normal or low, that is pulmonary embolism, obstructive. If wedge is high, it's cardiogenic shock. Just remember that circulation, how the blood flows. If you remember how the blood flows, and you know the nature and definition of the shocks, it's easy to figure it out. Okay? And now, these are the kind of fluid you use depending on what your patient has. I put this here for reference. If your patient is vomiting, you probably want to use lactate solution. Did they talk about this in diagnostics? Did the CAT talk about it in GI? Okay, this is self-explanatory. I just put it here for you to know the kind of IV fluid you replace depends on the kind of fluid the patient is using. Okay, some IV fluids have potassium, some don't. Right? Some is just free water, other stuff. And this is just telling you the kind of fluid losses you can use. And so review that yourself. As you can see, when your patient is in shock, you cannot treat them blind. You have to be monitoring everything. So we monitor mental status, skin appearance, arterial pressure, CVPs, pulmonary occlusion pressure, also known as wedge. You monitor urine output. Under normal circumstances, normal human beings will make urine at the rate of 1 ml per kg per hour. So you monitor urine output. If in 24 hours your patient has only made 20 cc, you're in trouble. The patient is going into kidney failure. So you monitor everything. Okay, mixed venous O2, base deficit, blood lactate. These are all things you monitor by lab, and you've been in ICU, you see all those lines and all those blue lines, green lines, red lines, all monitoring the patient. When your patient is in shock, the pulmonary artery catheter is always left in place. So when they want to measure the wedge pressure, they will just come and they will inflate the balloon and see what it registers. And once it's measured, they deflate the balloon. Okay? So, and once they inflate the balloon, this becomes a flat line and a pressure registers. Okay? That is known as the wedge pressure. Okay? Good. That's home run, man. Okay. All right. Any questions? I know I gave you a lot. I think it's a mistake to have done cardiology in the afternoon. It should have been cardiology in the morning, right? I will never do that again. Yeah. All right. But let's see how much of it you're able to retain. You did very well, by the way. So, you want to do some questions for yourself, Aaron?
Just go straight at the class. Yeah.
Okay, Kiara, take it first.
Damn.
Okay, let's do this. Okay. Right. So here is a 45-year-old male, hypertensive diabetic, with a history of COPD. On maximum doses of amlodipine, rosiglitazone, metformin, presents with progressive swelling of both legs for 4 weeks. Abdominal swelling associated with dyspepsia for 2 weeks. Physical examination is significant for bilateral pitting pedal edema, a loud P2, and a diastolic murmur at the left upper sternal edge. The murmur increases with inspiration. The first heart sound is normal, and the lungs are clear on auscultation. These signs and symptoms are consistent with which of the following diagnoses. So let's analyze this patient. So this guy is coming in with leg swelling, right? And dyspepsia. Right? So something is wrong. It looks like a right heart problem, right? And the leg has swollen too. But then you say it has a loud P2 and diastolic murmur. A loud P2, a diastolic murmur means this patient has pulmonary hypertension, right? Right? Loud P2 and diastolic, because there's so much pressure in the pulmonary artery, it's leaking back into the right ventricle, right? So this patient has pulmonary hypertension. Right? And it's already putting strain on the right heart, right? Why is it that the patient's lungs are clear? Because the right heart is failing. The right heart is the one that will pump blood to the lungs to congest it. If it's failing, the lungs will be clear, right? So, the lungs are clear. So what do you think is going on here?
Okay.
Exactly, called pulmonary, right? Good. Anybody needs clarification on this one?
Wait, again, you said the lungs are clear because the right heart is
Because the right is failing. Because remember, the reason you get pulmonary edema is because the right heart keeps pushing blood into the lungs to get it to the left heart. But when the right heart fails, your lungs don't get congested. The only time your lungs get congested is when your left heart fails and your right heart keeps trying to pump blood into it. When it's a pure right heart failure, lungs are clear. You got that? Excellent. Okay. All right, let's see this one. Yeah, this is the same patient, right? The same patient. The question now is, which of the following must be included in the treatment plan of this patient? So we said this patient has pulmonary hypertension. What do we want to give this patient? Do we want to give preload reduction with parenteral loop diuretics? We want to do afterload reduction with nitroprusside? We want to give him victimization? We want to do all of it? Or you want to do none of it? It's pulmonary hypertension.
Don't you want to increase the fluid?
Preload.
So, preload reduction? Excellent. Good. Yeah, okay. Good class. It's preload reduction because remember, nitroprusside does not dilate the pulmonary blood vessels. Right? It does not. If it was systemic hypertension, yeah, you can give nitroprusside, it would dilate the arteries, the systemic arteries. Why would you dilate the systemic arteries in somebody with pulmonary hypertension? Doesn't make sense, right? You got that? And of course, you never want to digitalize the right ventricle. Why would you do that? The ventricle is facing an obstruction. Why are you flogging it? It's like you face a horse to a wall and you keep whacking it. It's not what you want it to do, right?
Quick question.
Yeah.
Which is the one where you want to increase the volume to help?
Acute right heart failure.
Acute heart failure.
Acute right heart failure. Yeah. That's why I put these questions here. All right. So this is the same patient. The same patient. Now the question is, the same patient. The question is, what is the best treatment response to diuretic-induced hypertension? So you agree that you should do aggressive diuresis to decongest the patient. And now your patient's blood pressure is dropping. What should you do? You've done aggressive diuresis, but now you're dealing with hypotension. What should you do? Should you stop diuretic and start norepinephrine? Should you stop diuretic and start normal saline? Stop diuretic and start nitroglycerin? Do all of it or do none of it? You're not going to give nitro, Christian doesn't think. Anybody will give norepinephrine? Exactly. So what do you do when what does the patient pee when you give them Lasix? They pee salt water, right? So stop the Lasix and replace the salt water.
So saline.
Right? So you stop the diuretic and start normal saline. There is something I forgot. Oh no, I told you already. So if I give you 1 liter of normal saline, how much of it do I expect inside your intravascular space? Normal saline, 1 liter.
100 of it.
Tell me how you got to the 100.
I remember the slides.
Okay, you know that is important. You need to know that. So what is your next class?
4.
4. Okay, I'm going to be done in 5 minutes. Just bear with me. Okay, I can stop if you want me to.
No.
Okay, thank you. Right, so you see, remember, everything distributes. Water, 2/3 of the water in your body is where? Is it intracellular or extracellular? 2/3 of the water in your body is intracellular space, right? 1/3 is in the extracellular space, right? 2/3 of the water in your extracellular space is where? In interstitial space. And 1/3 is in the intravascular space. So if I give you D5W, 5% dextrose, your body metabolizes the glucose, converts the whole thing to water. 2/3 of it is going to end up inside the cells, and 1/3 of it is going to end up outside of the cells. Of this 1/3, which is really 300, 200 is going to remain in the extravascular space, and only 100 cc will make it into the intravascular space, because it's going to distribute just like free water. But if I give you normal saline is sodium water. Sodium is mostly going to be in the extracellular space because sodium is controlled, right? So if I give you 1 liter of normal saline, which is sodium water, 2/3 of it, with all of it, actually 100 of it, will be in the extracellular space, right? 2/3 will be extravascular, extracellular, and 1/3 will be extracellular, intravascular. So I'm going to be able to get 300 of this 100 cc into your intravascular space. That is the reason you don't give D5W to somebody in shock. You're wasting the water. The drip will end up, you understand that, right? It's based on the distribution of sodium. Sodium is an extracellular cation. So all of it stays in the extracellular space. 2/3 in the extravascular and 1/3 in the intravascular. So if I give you 1 liter of normal saline, I will expect to get at least 300 into your intravascular space. But if I give you 1 liter of D5W, only 100 cc will make it into your intravascular space. Okay? All right, so you got that right. So let's do this one. Here is this 35-year-old female with heavy menstrual bleeding for a long time. She presents with 6-week history of progressive dyspnea on exertion associated with autopnea, PND, and swelling of both feet. So she looks like she's in congestive heart failure, right? She denies chest pain and has no other past medical history. She's young, so we don't think it's coronary artery disease. Physical examination is significant for a pulse rate. She's tachycardic, she's pale, right? She has bilateral patent edema. The patient is dyspneic at rest, so this is New York Heart Classification 3 or 4, right? Actually 4. And she has fine basilar crepitations. She has an S3 gallop, so she's volume overloaded, right? Initial laboratory test result is unremarkable except for hemoglobin of 4.5. So she's still anemic. Hematocrit is 14. Now the question is, what is the most appropriate sequence in the management of this patient? You're gonna give whole blood? Is that right?
Too much fluid.
Exactly. You're gonna give Paxil followed by loop diuretics? Or are you gonna give parenteral loop diuretics followed by whole blood? Parenteral loop diuretics followed by Paxil? Which one would you do first? Would you give the Lasix first or get the Paxil first? Because you all know this. You know how long it takes to get Paxil? You have to draw the blood and then send it up for type across, right? So the best thing you will do is you will give the Lasix. While your patient is diuresing, you're waiting for the blood. Then when the blood comes, you give the blood. So the Lasix will at least decongest your patient will feel better. If you've been in the emergency room, you know how long it takes to get Paxil from the blood bank. You would have answered it correctly.
You should consider that symptom. I mean, you're gonna go with what's bothering you.
Exactly, yeah, you're going to do it. But the truth is, would you rather leave out this snake at rest for the 2 hours it takes for the blood bank to give you blood? Or you're going to give her Lasix now and she can be feeling better while you're waiting for the blood? Right? You got the reason now, right? Okay. So, how much of 6 liters of normal saline infused into a patient with hypovolemic shock following prolonged vomiting and diarrhea is expected to reach the intravascular space? 6 liters. Normal saline.
2 liters.
Thank you. 2 liters, right? Everybody got that? If it was D5W and I put 10 liters, how many liters would I get in the intravascular space? 1. Okay? You remember? Because D5W would distribute like normal water. 2/3 of it will end up inside the cells. 1/3 will stay outside of the cells. Of the one that stay outside of the cells, 2/3 will stay in the interstitial space, and 1/3 will end up in the intravascular space. Okay, so at the end of the day, it comes down to be like what? About 100 cc. Okay. You got that? Okay. D5W is glucose water.
Sugar water.
So if I give D5W to a patient, let me slow down because I don't want to. I need to make sure you understand it. So if I give D5W to a patient, the patient will reduce it to nothing but water in minutes by metabolizing the glucose. So that water will distribute just like water distributes. 2/3 of your body water is in the intracellular space. 1/3 is in the extracellular space. Among the 1/3 in your extracellular space, 2/3 is in the extravascular space, and only 1/3 is in the intravascular space. So if I give you 1 liter of water, 700 cc will be inside your cell, 300 cc will be outside of your cell. Of the 300 cc outside of your cell, 200 will be in the extravascular space, and only 100 will make it into the intravascular space. Because it's ordinary water. Right? Right?
Wait, can we solve one?
No, that one is, I'm talking about D5W.
Oh, this is
But now, if I was to give you normal saline is sodium. Sodium will be restricted to the extracellular space. So none of it will go into the intracellular space. All of the 1 liter will stay right here in the extracellular space. But of that 1 liter in the extracellular space, 700 now will stay in the extravascular space, and 300 will go into your intravascular space. That is why we use normal saline for resuscitation, not half normal saline, not D5W. Because more of it will end up in the intravascular space where you want it, because your patient is in shock. You got it now? Excellent. Good. I'm happy when you guys get it, because I know you get it. And I can feel good testing it. All right, so let's do this matching. This is the real deal, okay? So here are cases and these are the values. So I want you to match these values over here to these shock states. So let's start with the first case. CVP is high, right? Wedge is high, that means the tank is full, right? So stuff is getting to the heart. But cardiac output is low. Nothing is leaving the heart. Blood is getting to it, but nothing is leaving the heart, right? And because cardiac output is low, the systemic vascular resistance is high because the body is trying to maintain blood pressure. So this is normal response to low cardiac output. The pulmonary vascular resistance is normal, so there is no obstruction in the lung. So what do you think is going on here? Thank you, you got it. I knew you get it. All right. So is there anyone here that doesn't understand why this is cardiogenic shock? It's straightforward, right? Excellent. Now let's take number 2. CVP is low, wedge is low, that means nothing is getting to the heart.
Bless you.
So because nothing is getting to the heart, cardiac output is low, right? And the body is trying to maintain blood pressure, so systemic vascular resistance is low, is high, and the lungs are clear. So what is this? Good! Hypovolemic shock, right? So let's do number 3. Question? You're all with me, right? Okay, so number 3, CVP is high, but wedge is low. So somehow it got to the right heart, but it didn't make it over to the left heart, right? And because it didn't make it over to the left heart, cardiac output is low, right? And because cardiac output is low, systemic vascular resistance is high. But pulmonary vascular resistance is also high. So what is that?
Pulmonary embolism.
Pulmonary embolism. You see how easy it is?
Yeah.
Excellent. So let's do number 4. The CVP is low, so nothing is coming to the heart. For sure, nothing is getting to the right heart. Nothing is getting to the left heart. So nothing is coming out of the heart. And the systemic vascular resistance is low. Is that what you expect? No, that is abnormal response, right? And pulmonary vascular resistance is low. What is going on here? Thank you. Neurogenic shock. Under normal circumstances, when cardiac output is low, at least systemic vascular resistance should be high. But when your cell phone is cut off, you're not communicating. So that's what happens. Now, the last case, CVP is low, wedge is low, so nothing is getting to the right heart, nothing is getting to the left heart. Cardiac output is high, systemic vascular resistance is low, pulmonary vascular resistance is low. What's going on here? Septic shock, right? Blood is staying away from the heart, and the heart is trying very hard to keep pumping blood. I think that's my last slide. Oh no, it's not. Okay, all right. This is the last one, I believe. It's not. Where's the last one? Okay, 2 minutes. So here's a 72-year-old male, hypertensive diabetic smoker, with a history of congestive heart failure and renal cell carcinoma. The patient is status post, which means just had surgical resection 2 years ago. Now patient presents with a 6-week history of progressive shortness of breath. He denies orthopnea, PND and leg swelling, and claims good adherence to his optimally dosed medications. And he's on everything. He's on beta blocker, he's on enalapril, he's on spironolactone, furosemide, aspirin, digoxin, the whole 9 yards. The guy is getting everything. He has also been hospitalized 3 times in the last 6 months for CHF exudation. Right? So this patient is one of the patients that you're losing. Is coming close to end stage, right? He's likely going to die suddenly if you don't do something now. Okay, vital signs. Look at his blood pressure. Look at his pulse pressure. Right? Pulse rate is 90 because it's beta blocked. Right? Otherwise, it would have been tachycardic, right? JVP is normal. His first and second answer are normal. There is an S3 gallop, so some volume overload. Lungs are clear. It's not in pulmonary edema. That is why it doesn't have PND and all that, right? But its lower extremities are cold. Ejection fraction 3 months ago was 15%. EKG shows an old MI. What are you going to do now? Thank you. ICD. You want to prevent sudden death in this guy. So you give him ICD. And if you can get him on transplant list, you do that too. You got that? Yes. Excellent. Yeah. I'm so proud of you. You know? I mean, believe you me, I have fellows, cardiology fellows, figure some of this out and they flunk. So I mean, just the fact that you guys can grasp it makes me so happy. Because I'm a firm believer that if you, Albert Einstein says, if you cannot explain it simply, you don't know it enough. You know? So you guys make me really good. All right, so let's do this matching. Tricuspid valve opening and passive ventricular filling is what? E, okay. You said you want to do this as a class, right? Yeah. Is it a one-person class? Tell me what it is. Tricuspid valve opening and passive ventricular filling. What is it?
Is it a B?
Okay, maybe let's do elimination.
No, it's, yeah.
Tricuspid valve closure. B, right? Excellent, that's correct. Atrial contraction and active ventricular filling.
That's A.
That's A, right? Ventricular contraction.
X? No.
Good. And atrial filling.
What's that? The Y?
B.
No, that's
the
B.
B.
That's
Is that
B.
B?
That's B. And the first one is.
Oh, that's the right. Tell me what is right. 1. You don't know. 2.
Oh no, that is Y.
Tricuspid valve closure is what?
What is B?
C wave, right?
What is B?
Wait, it's right.
C.
Yeah, C way.
B. Okay. All right. Atrial contraction and active ventricular filling. Okay, that is it, right? Ventricular contraction. X.
Atrial filling is
Atrial filling is X.
Yeah, that was B. It's the B way, no?
What is B?
I am so not happy with you right now. But let's think it. So, when the tricuspid valve, I didn't go through it because you told me that you did the physical diagnosis. That's why I didn't go through it. If I knew that you guys didn't get it in physical diagnosis, I would have spent more time on it. You want to figure it out, or you want us to go through it? Okay.
Number one is Y dip.
Huh?
One is Y dip.
Yeah, where you're getting confused is the Y and X thing.
Yeah.
The question is which one is first? Is it Y or X? X is first, right? Okay. So it's a dip. So if it's a dip, what happens?
Blood is going.
When would it dip?
When the blood is opening up, so it moves.
No, actually when the ventricles is in systole and the atrioventricular ring is down. Right? So that is what really happens when systole is at the peak in both ventricles and the atrioventricular ring gets sunk down with the negative pressure inside the ventricle. So let's start with that. So basically 4 is really deep. Alright, I think that's what you said. Right? Let's start with 1. Tricuspid valve opens and you have passive filling of the ventricles.
Why did?
Why did exactly?
You're saying E.
I was only writing, I wasn't even judging your answer. Alright, so that is it. It is Y, number 1. And then when the tricuspid valve closes, that's when it creates that C hump, right?
Yeah.
When atrial contracts, that's what it is. And atrial filling, thank you. I think that's my last one.
You didn't say that. Okay. Wait, go back. That was